Good afternoon, Dr. Malti.
Hello.
Hello.
Yeah, Dr. Malti here.
Yes. Good afternoon and welcome. The session will be start at 2 p.m. sharp.
Yes.
Right. We have 15 minutes.
Yeah. Sorry, is it Puneet speaking?
Yes, people. Yeah.
Oh, hi, Puneet. So the presentation I'll try to share from my end.
Okay.
In
Fine.
case there is some difficulty or a technical hassle, I've also shared, I think, by mail my presentation.
Yes. Received. Well received.
Yeah, good. So in case there is a technical hassle, I might request this thing to be shared, presentation to be shared from your end.
Sure. Sure.
Okay,
Sure. Doctor. Thank you so
great.
much.
Thank you so much.
Puneet.
Anji sir. Hello.
Just a minute. So you are able to connect with Mr. Professor Naveen?
Yes, sir, but I'm not sure he will be joining on that. I'm not
Okay.
getting that permission.
No problem.
We have Dr. Malti and Dr.
Yeah.
Varsha.
Okay. And Mr. Gaikwad?
Good afternoon, Dr. Garg.
Good afternoon. Good afternoon. Dr. Malti.
Hello, Dr. Malti. Also, so nice to be with all of you. Are the others also joining or?
Yeah. Within next 2 minutes.
Hello, Varsha.
Hi, how are you doing, Dr. Malti?
Good, thank you. How are you?
Good, good.
So, Dr. Malti and Varsha, we can start because Tim Peterson is also here. He has sent his video presentation.
Okay, so recorded one, right?
Yeah, recorded. So that will be at last.
No, sir, we have not received yet video. Maybe he will be joining us.
He may join. Okay. Okay. So within a minute, we will start. So welcome all distinguished speakers. This session is plenary 3, Health Economy, Innovation and Research for New Normal Digital Health Solutions. And this is chaired by Mr. Naveen Seth, Vice Chancellor, Gujarat Technical University. I had to say a few words before I hand over to Mr. Naveen Seth, Dr. Naveen Seth, for chairing the session in which Dr. Malti and Dr. Varsan Narayan are there. Tim Peterson will join later, and we will see how best we can have this session. Dr. Gaikwad has also joined, so welcome, Dr. Gaikwad.
Thank you, sir.
Thank you. One thing I will like to share with you that from last few years, I'm just searching for innovation. Innovation. Hello. Yes. Yeah.
Unmute, sir.
Distinguished speakers, I want to share one important aspect that from last few years we are searching innovation in healthcare. Innovation, and that will reduce the cost of equipment, medicine, supply, and the process. So I could not able to find any authentic by this time, though there are many innovations are happening around the world. So my request is, if you come across any scientist, any doctor, any company, any individual who has made a dent in the healthcare industry on innovation aspect, and particularly for healthcare of poorest of the poor, that is reducing the cost and increasing the efficiency, then please recommend us. And next year we will see that it will be in-person conference at Delhi, and dates will be 12 and 13, not 14. Okay, because 14 lot of problems are there, and so dates will be next year 12 and 13 April. That will be constant. So I will hand over to distinguished Vice Chancellor of Gujarat Technical University, Mr. Naveen Seth. Mr. Naveen Seth, please. Mr. Seth, unmute yourself.
Yeah. So I'm audible now, please.
Yes. Yes.
Respected all dignities, all participants here in this important conference of World Healthcare Conference 2022. Very first, I congratulate the organizer for this important conference with a different important topics related with the healthcare. So today I have to chair the session with the distinguished speakers here, Dr. Madhukarji, Dr. Malathi, Dr. Varsha, Dr. Tim Patterson, and in this session. So actually, the said that the innovation during the pandemic time, my university, a technological university, and we have created a very good ecosystem for the innovation. Previously, the educational institute, the scenario in India is like that. If any students coming to their teachers, contact their teachers with some new idea. But what happened when he go to their teacher, the teacher said, okay, your idea is very good, but you focus on exam. Very first you finish your exam and then you do whichever you like. Means we are crushing the idea, we crushing the creativity at the educational institutes. This is the hard fact. But slowly, under the new leadership of our Honorable Prime Minister, after 2015, the providing the platform to the students for nurturing their idea, that is slowly the ecosystem is developing in a different university. In my university, it is a affiliated type of university. 500 colleges are affiliated with my university and about 5 lakh students enroll in this university. So it's a largest university of the Gujarat and jurisdiction all over the Gujarat. But we have created an ecosystem in my university with a regional center also, means throughout the Gujarat. Launched various schemes to nurture the idea, to support the idea, and end-to-end support system is developed. And the results are very good by our students. There are 70 companies were established and they have recruited, given employment more than 700 peoples, and they are earning about 16 crore rupees during this journey of startup and innovation. But here we are discussing about the healthcare conference and innovation. So during this pandemic time, a number of students with a different idea, particularly related with the healthcare, and we have supported them. Our one students, we have a very good startup by that students, that the mask, he prepared a mask, a medicated mask. So in N95, the viruses are blocks 95%, but this medicated mask blocks the virus as well as kills the virus. It is a medicated mask, a very good mask. Now it is exporting also. So there is a different system is developed during this pandemic time. The remdesivir injections, adulterated injection in the market. My faculty has developed a system to identify within 3 minutes by the HPLC method, and we are testing that remdesivir injection. So that method and everything is published, and the Agilent company has given the RT-PCR machine in a gift towards our social activity. And we are given during that time the RT-PCR test free of charge we have done during the under the ICMR approved lab. That machine is used for the public. So number of other innovation during the pandemic time, and our one students with a drone technology, he helped the police department for monitoring the different area to supply the medicine by the drone and other thing. So that is also by one of my students at our incubation center. Our Niti Aayog has sanctioned the Atal Incubation Center at my university, and they have given the grant of rupees 10 crore rupees. So I think this is the brief of my university during the time, this pandemic time. So thank you very much. Hello.
Hello.
Yeah.
We request Dr. Malathi to please present the presentation.
Thank you very much. Thank you for giving me an opportunity and invite me here for this presentation. And Professor Naveen Shai, it was indeed wonderful to listen to you and to see the type of innovations that have been done, and more importantly, the encouragement that is being given. I think as a Vice Chancellor, this is something which is very remarkable and will go a long way in all the countries. That was very, very interesting. And I think you spoke with a lot of passion and compassion. That was really interesting. So very happy to be invited and to take up the first topic. Allow me to share the screen, please. So I'll share the screen. You need to tell me whether you're able to see it. Yeah. Is my screen visible?
Yeah.
Yes, yes.
Okay, thank you very much. So my presentation that I would be taking up at this point in time, the title that has been given for the plenary session is Health Economy, the New Normal Digital Health Solutions. So I'm Dr. Malti. I'm the Group Chief Medical Officer and the Group Chief Quality Officer for the Aster DM Healthcare, a group of hospitals, medical centers, extends both in India as well as GCC. In both the geographies, we have hospitals, medical centers, total of about more than 30 hospitals and 65 medical centers and over 250 pharmacies. So this is a very, very interesting topic and more important, very pertinent to the present situation. So let me start based upon the topic, which talks about health economics, and it is also at the same time digital healthcare. So I'll start by defining what is health economics. And in this particular aspect, the health economics, what actually makes up healthcare economics. And first and foremost, it is all about spending for the growth. It is about the consumer, and here the consumer is our patient. It is also about the provider for the care, the healthcare providers, and that includes the doctors, the nurses, the paramedical staff. All of them play a role as healthcare providers. What is the impact of the risk and the insurance system? Very important is designing and the benefits and the payment reforms. All of these together makes up what is called as healthcare economics. Having said this, the second part of this particular topic includes digital health. And when we talk about digital health, I'd like to define a few important criteria of digital health. And these include, number one, when we say digital health, what is it basically? It's an integral part of the health priorities and should benefit the people. But important here is it should be ethical, safe, secure, reliable, equitable, and sustainable. In the next few minutes of my talk, you will see these words coming up again, particularly when we talk about secure, reliable, sustainable parameters, which is very, very important in digital health solutions. Second very important aspect of digital health, it should be developed with certain principles, because we talk about digital health all the time. So what are the principles that comes into play for digital health? And the principles are transparency, accessibility, scalability, replicability, interoperability, again is privacy, security, and confidentiality. Why are these particularly important? Is that it should be accessible. You may have the best of the digital solutions, but if it is not accessible across the group, it still does not serve the purpose. Scalability, because of the era of research, there are leaps and bounds in the various platforms that come. So what you have today is probably redundant tomorrow. Therefore, the solutions could be scalable and very, very important end-to-end solution from the time a person wishes to have healthcare to the time that he leaves the hospital or even reaches the home. Is there continuity in the provision of the healthcare? Privacy and security is the need of the hour because it is highly personal information. And therefore, the digital health system should be able to ascertain that my health records is safe and secure. The third very important aspect when you talk about digital health is the focus should be on improving the performance, productivity, efficiency, security, without sacrificing reliability and accessibility. So friends, what I'd like to see in all the three, there are certain criteria which are again important. And these, as I told you, is secure, reliable, accessible, sustainable. All of these form the pillars of the good digital health. Therefore, most important at this point in time, friends, why are we talking about healthcare as well as health economics? And finally, it is for health well-being. And therefore, in all of these, it is important to focus on the cost efficiency, the effectiveness, production, consumption, what are the resources available? Are they as per the demand and the usage? And what is the healthcare market? So simple enough. Very, very interestingly, the world's most efficient healthcare, they have been scored, and that is called efficiency score. And these colors clearly indicate to us that certain areas where it is dark green, it is more than 80. The score is 60 to 80, where it is a little bit of a lighter green, further becoming 40 to 60, further lighter shades of color going to 20 to 40, and those are certain areas which are less than 20. So it's important to see how efficient is the healthcare system. Today's topic, which is on health economics, at the same time digital health, I'd like to bring up a pertinent point, the need for adoption of digital health. Why do we need digital health in this era? And the question can be answered by the fact that there is medical advances. Very important, the population is going into increased life expectancy, which means we are going to have more vulnerable group of people. And along with vulnerability comes the added disease condition, the chronic disease management. So we need to prepare the digital health towards this increase in life expectancy. A very interesting phenomena that has taken place at this point in time is the consumer, the patient, talks about shift to care anywhere. Now, what does this mean? I, as a consumer or as a patient, would like the care come closer to me because it is becoming more and more difficult to reach hospitals. The patient or the consumer now feels it would be better that the care comes to me at my home, and it is not always necessary that I need to visit the hospitals at all, because it could be just refill of medications. It could be just a physiotherapy. It could be a blood collection. I really don't have to go to the hospital. Can the hospital service come to me? The digital health solutions provide that requirement of shifting the care anywhere. Another important aspect is constant advances in health research is absolutely pertinent. And this we have seen in the development of the vaccines and other things which are required during the need, during a pandemic. All of these, why do we aim at? Is because digital health improves consumer experience, because everything is decided by, the quality is as decided by the receiver and not the provider. So friends, the consumer decides how efficient is your service. Therefore, what we expect is improved consumer experience, and the customer priority is primary convenience becomes important. The most important currency now is convenience, and therefore the focus on digital health. Having said that, how do we marry the two? The health economics along with the digital health, and that is by efficient health services, establish the cost that it is accessible, affordable to the large set of the global population, evaluate the cost and the benefit, and that is what is health economics. And finally, estimate what are the variable factors. The time, the distance, the cost become variable factors, and all of these constitutes health economics. But what does the digital solutions help? They give you seamless experience, reduced contact, urgent care, providing low cost to the patient, expanded access, which means you reach them at their home step, and there is continuity of care and remote monitoring. So these has resulted, today we are talking on this topic is because there has been a seismic shift in healthcare. There is a collision of forces coming up. And what are they? The global pandemic, which we are talking about. There has been exponential advance in medical science. There has been explosion of digital technology, access, analytics, and last but not the least, your consumers have become empowered. They would like to take the decisions. In fact, it is participative decision making. The consumer knows what he or she needs, and therefore this has become a shift in the healthcare. Coming to what has made a change, COVID-19. Very often in the initial part, all of us have always felt it's a great challenge. And that had a pessimistic attitude. But now we know very well it has been a catalyst. Unfathomable, calculable impact has been there. Some of the impact is still not fully understood, but there has been a stalling of global economy. What has it resulted in? Some important outcome. It has caused a reducing of the headcount. It has caused temporary leave of absence of people from work. And finally, remuneration packages. All of these has had a global impact. Having said that, a very important aspect is the pandemic is a catalyst to kickstart and accelerate a number of changes in the healthcare ecosystem. And this has been the World Economic Forum describes the post-19 economy as the Great Reset. We ought to understand how do we build back better. There has been a setback, no doubt, in the last 2 years of the surges, but how do we build back is the question. And how do we do that? The world's advanced economies have taken bold steps to build back. And these are the economies that are going to prosper. Very, very important. We have come to a concept called circular economy, which is reducing wastage. Protecting the land and water resources is what is important for people's health. But last but not the least, the government to shift to a circular economy for a sizable 12% GDP. This is how we are going to get back our economy. Therefore, the healthcare sector will now focus on equitable care, which means availability to everybody, the rich, the poor, needless to say, race, religion, caste. It has to empower the consumer. How do I jump back? It should focus on sustainable practices. It cannot be one-time solution. It has to focus on mental health, behavioral health, and very important, women health. A transformation has to take place in healthcare delivery itself, which is the digital transformation. The future of medical sciences, which is research, has to be the focus. So we are prepared in advance in the event of a next pandemic. And all of these can be achieved through public-private partnership. That has been the very important focus. Hence, we have established health equity institutes. And what do these institutes focus on? The most important one of these, the 3 root causes that can prevent equitable health outcome is racial, socioeconomic, gender, and other biases should be overcome. Disparate circumstances in the drivers of health. Everybody should have an access to the health, as I mentioned, from the rich to the poorest of the poor. And there has to be complete, adequate healthcare system. This is what will establish the whole commonality. It is good to know, friends, that the WHO has set the digital guidelines. And though this is a busy slide, all we ought to know that from the birth, it is all the way down where you can be accessible, providers should be there, competent people, commodities must be available, trained people, good evidence-based practice, they give appropriate care, and very, very important, the health workers follow up, continuity, and finally, of course, it is inevitable, death registers. All of these have been very, very well established. Therefore, friends, we come to a very important aspect, that is innovation. The whole talk initially started, and I'm very happy, it began with innovation. And I come to that important point, that disruption leads to innovation. And that is what is important at this point, where we need person-centered care, evidence-based practices, skill and competence for the professionals. This is a hardcore reality. And how do we achieve innovation? There is plenty of data available. There has to be data analytics. There has to be a digital well-being, which means IoT, virtual care, remote monitoring is the need of the hour. There has to be web-based solutions, smart wearables, platform tools, clinical trials. Very important, we ought to focus on preventive health, which is digital therapeutics, and self-care, which is very, very important. The technology, now coming into marrying the economy with technology, the types of healthcare technology, there is a boom of healthcare technology, and that is because we need continuity of care, efficient care, operational efficiency, and last but not the least, financial. And how do we achieve this? There are 2 important hemispheres that you can see here, which is digital health categories and digital monitoring smart apps. And what is this digital health category? Digital imaging, like the CT and MRI, robotic surgery and microsurgery, patient monitoring systems for well-being, as well as data streaming. And on the other hand, every consumer wants to be self-sufficient. As a patient, as a consumer, I would like to know how I am doing well. So I must have an active monitoring system of monitoring my own sugar. What is my blood pressure? What is my ECG? Therefore, monitoring systems that I can use, which are the various apps. Position monitoring, less number of falls, sleep monitoring, cardiac monitoring, all of this have become a part of the healthcare technology, and that is what we call as transformational health. What is transformational health? It is artificial intelligence. The patient experience, the patient would say, I'm at home, I would like the doctor to move closer to me. So give me the health aspect in my hands. I shall monitor mine and relay it to you. And that important aspect improves patient experience. What are we achieving? Patient empowerment. Patient can monitor his or her own health. I can monitor my own blood sugar and get back to the doctor. I can provide patient advanced physical, paraplegics, robotics have been given where they have become self-sufficient. And finally, everything culminates in effective care. And that is what is required, the health economy to match with transformation health. Friends, we need to go into the next era, and that is digital therapeutics, where we have visual recordings happening. Time to go into digital companions like digi-inhalers, nanomedicine or nanorobotics, which looks at the molecular level, and genomics, which tells us, do we have a predisposition, which is DNA sequencing. This is the transformation the economy should provide, and the development of smart cities, which are nothing but technologically modern urban areas, sensors monitoring, AI for collection, integration, interoperable, real-time, and health and wellness. And great examples that you can see here, these are the evolving smart cities. Having said that, we then look at what have we at this point in the health economy. The wonderful national rollout of the Ministry of Health and Family Welfare, the Ayushman Bharat Digital Mission, we call it as the ABDM, has resulted in a budget of 1,600 crores over the 5 years. And this mission will be implemented by the National Health Authority. And what is a very important purpose? This is the vision. The ABDM aims to create the seamless online platform. This is what is the health economy and the process of transformation, because it will enable interoperability within the digital healthcare ecosystem. A very important aspect of this mission is what we call as digital building blocks. Each building block is seen as a digital public good that can be used in the digital ecosystem. Key capabilities of this vision is what is this Ayushman Bharat and what is the health economy. The union budget has allocated 86 crores, which is almost 16.5% more than the previous estimate. And that shows the importance in the investment towards digital health. Certain facts and figures before I end. The market size is anticipated to be valued at $1.5 trillion by 2030. And why? Because it is going to improve the internet coverage, growing chronic disease, smartphone penetrations, the need for virtual care, and increased accessibility. A very important leap in health economy is that the telehealthcare segment dominated the market in 2021 with a revenue share of 37.6%. Why again? Increased preference for remote patient monitoring. We moved into a virtual world. Home care, teleconsultations, all of them have come. Virtual consults. Patients could not reach hospitals. So what did we invest in? We looked at remote monitoring. We said, we bring care to you if you are unable to reach us. And therefore, the service segment dominated the global market with 45.6% of the market revenue share in 2021. And why? The demand for pre-installation and post-installation services. Very interestingly, North America dominated the market by region with a revenue share of 45.9% because of rapid IT infrastructure in leaps and bounds to provide the consumer. Therefore, friends, the digital health market size has boomed and had gone on to almost from 2020 to 2027. You can say it has gone from to $551.0 in billions has been as seen in this graph from 181 to 551. That is the level of the boom in the economy towards the digital transformation. And at the end, simple question, why all of this boom in infrastructure? It is because it is all centered around that patient who's writhing in pain in the beds of the hospitals and at home sometime. And this particular person decides what is required, and that has caused the boom. And what is this personalized care? When you ask a patient, what is it you want? And the patient has one answer, and that is, please be there for me when I need you. And then says, tell me when and how do I need to take action? And how can you provide the answer to this? It is only possible through digital healthcare system, because you can be there for the patient anytime, anywhere, through the digital systems. And that is where economy and the digital system go hand in hand. Thank you very much for a patient hearing and the opportunity to present the need in the boom and the interaction between the health economy as well as the digital transformation. Thank you. Thank you very much.
Thank you, Dr. Malti, for a very nice presentation covering all such topics from due to this pandemic, how it is act as a catalyst and this total transformation in healthcare system. You have covered number of topics from robotic surgery to the teleconsultation, the use of artificial intelligence and smartphone penetration. So number of topics related with the health economy and this transformation. So thank you, Malti, for a very nice presentation. Thank you.
Thank you. Thank you.
Yeah. Yes, next, Dr. Varsha Narayan. Dr. Madhukar Gaikwad.
Hello.
Yeah.
I am audible.
Yeah.
Yeah. I am Dr.
Yeah.
Madhukar Gaikwad. Good
Yes.
afternoon, everybody. All eminent speakers. I am head of medicine unit in Grand Government Medical College and JJ Group of Hospital in Mumbai. As a previously additional charge of medical superintendent. Madam has very nicely explained or highlighted so many things. So just I point out this pandemic era or post-COVID or during COVID era also, whatever we face or we have learned or we things or invested new things, so many new things from the so many faculties come in this pandemic situations. Simple things I want to highlight, like in our medical colleges we saw when in started the new smart OPDs when in COVID patients, everybody is so much panic. In these conditions, so many patients, they wish doctors or any hospital faculties or hospital medical or paramedical people are very panic situations to how to handle the patients or how to patients or your doctors also afraid to touch the patients. So simple innovation like a stethoscope have innovated in our medical college also, which simple medical stethoscope there is no need to test the patients also. When we that a patient will is test his own and we have sees his pulse rate or his heart rates or any auscultative sound of lungs, or we can observe or we or pandemic era. Next, in our also we have prepared or made the one chamber from the our hospitals like surgery departments. Their HODs or involved are their faculties. So they have prepared very good very good one chamber that is we can use for the transport of that patient. That chamber has no infections to others. They have fully covered with all facility inside that chamber or with also oxygen supply when we shift that patient to other things to get the CT scan or other investigations. So I saw this also very new innovations in our medical college, which is only innovated by the our hospital doctors. So these things I also observe in this COVID era or pandemic situations. And other things I want to highlight one simple things. When patients are at home or so many doctors also at home or sometimes patient in hospitals. So they want consultations. So we consulted these patients through the video calls or other through any on like telemedicines. Telemedicines are already in government setups in our or India or in states also. While we are these teleconsultations or telemedicines or video calls, also we observe so much use of these things in pandemic or COVID situations. And other already also one thing also madam also told ki self monitoring of blood sugar levels that is called SMBC. These are also simple things where digital thermometers or digital BP apparatus. These are also where new things was used by the so many peoples in these pandemic situations. So there is no need to do all these things by the any hospital doctors or any paramedical peoples. So these things are innovations or in things may be observed in these pandemic situations and other so many like robotic surgeries or nanotechnologies. In the futures also we'll see the so many nanotechnologies also very helpful in medical sectors or medical or for the patients benefits in health as well as the their prognosis or any diagnostic things also so many in this case I think I will observe like innovations in this era. Hello.
Yeah,
I
yeah.
think
Yes, sir. So these are my observations in this pandemic situation, sir.
Okay, Dr. Gaikwad.
Yes,
Yes, sir.
yes, Dr. Madhukar, you have given your practical experience and your observation. Hello.
Hi, yes, sir.
Yeah. So yes,
Yes,
Dr.
yes.
Madhukar, you have given
Yes,
your
sir.
practical experience and your observation nicely about the telemedicine and teleconsultation and digital apparatus and everything. Okay, thank you. Thank you, Dr.
Okay.
Madhukar.
Okay, thanks, sir.
Yeah. Now, Dr. Varsha Narayan. Dr. Varsha is here.
yes, I'm here.
Yeah.
And
Welcome, Dr. Varsha.
Thank you so much, Dr. Naveen. And I have shared my screen. I hope it's visible.
Yes.
Yeah,
Yes.
visible.
Okay.
Uh,
So,
Yeah,
firstly,
Dr. Varsha is a consultant family medicine and holistic health expert at National Health Authority, Clinical Research and Pharmaceuticals, founder of the uh, firm. Thank you very much. Yes, Dr. Varsha, please.
so good afternoon, everybody. Firstly, a big thank you to Professor Garg for having me in this wonderful conference with such eminent speakers who've shared wonderful experience and knowledge. And great to be in your session, Dr. Naveen. And to start with, I'd like to say that Dr. Malti has taken such a comprehensive presentation that I think there's not much left for us to add. She has covered all the aspects so beautifully and told us some very important attributes of digitalization, like equitability, the accessibility, the universality, the scalability. All these were very interesting aspects. So today what I intend to do is bring to you 4 aspects which I think have emerged from the pandemic and are very useful arenas, or I can say important buckets, in which we need to see digital innovation and have also seen digital innovation, but there is more to go and there is more that the heart wants. And I think we have, Dr. Naveen, you have such a wonderful institute and students who are engaging themselves in research. So I thought maybe these avenues would interest them, where I see a lot of scope for further innovation and also a scope for reaching out the healthcare to all socioeconomic levels in our country. So to start with, a quick peek at what the Indian healthcare looks like. So healthcare in India, which was about a 62 billion USD industry in 2017, is slated to reach almost 133 billion by 2023. Now, just to give you a perspective here, the global healthcare, which is growing at about 7 to 8% CAGR, is going to be at almost 11 to 12 trillion by 2023. And we are going to be almost more than 1/10 of that global healthcare. So that is a huge chunk that India is going to contribute to in healthcare. And against the global growth, Asia Pacific, especially Indian markets in healthcare, are growing at 13 to 14%, vis-a-vis the 7 to 8%. So we are a very fast growing Indian healthcare economy and slated to boom by 2023. That's not far, that's next year. Now, there was a very nice map that Dr. Malati had shown in her presentation, which was showing which were the countries which were excelling in digital healthcare. So over there, I was a little disappointed to see India not really up there right now, and India was in the gray zone. One of the reasons that I would like to put forward here is that how widely diverse our healthcare system is. And I think that needs to be understood before we come up with, blanket digital solutions. So if we see our Indian healthcare system, it ranges from basic healthcare and peripheral services on one end, which would be rural and in smaller towns, to advanced, the most advanced apex multi-speciality tertiary care hospitals. On one hand, we have government-run public services. On the other hand, we have private healthcare also. We have a whole wide foundation base of general practitioners vis-a-vis specialists who can also be directly approached in our country, which is a uniqueness, because in most countries you have to go through your general practitioner to access a specialist. But here we can do it directly. We can walk into a specialist, we can walk into a GP. And then, of course, not to forget, very, very important aspect, we have allopathy, of course, but we cannot forget our huge group of alternative medical practitioners as well. A lot of indigenous medicine, which still caters to a substantial population. So look at the variability here. We are dealing with such a complex healthcare system. Most countries have a very streamlined healthcare system and only one kind of practice. But here we have public health, where we are having about 25,000 primary healthcare centers, with 5,000 community healthcare centers trickling into 200 specialist tertiary care hospitals. And this 700 district hospitals are extremely important. They are probably the milestones across our country where a majority of peripheral healthcare is happening. Coming to the private health sector, we have almost 9 lakh doctors who are catering to the entire allopathic system, out of which there are 6 lakh GPs. And this is the last registration that we saw in 2019 with the NMC. 70% of households in urban areas and 63% of households in rural areas are catered to by private healthcare, which has its own affordability issues. And most of the digital innovation has come in this segment. However, we have this whole segment here and this whole segment here of indigenous medicine, which still needs to benefit from the digital innovations. So just putting this perspective about how varied, how complex our healthcare system today is, and how we have to get into digital solutions across this whole paradigm of healthcare, I have taken the opportunity to bucket some of the digital healthcare innovations in the form of an ABCD. This is from my insight of the pandemic, where I felt that we have done good work, but need to strengthen these 4 aspects for effective digital healthcare solutions. So when we talk about health awareness, I think this is something that we're very proud of, that we have access to medical information at a button. So everybody knows medicine today. So when I have patients coming in, they come with pre-existing knowledge. They have read up everything on Google through a lot of health sites, and they think they are very aware. But I think the whole issue was the awareness the right awareness? What we really need is interactive digital platforms for credible and relevant medical information with guidance. We have a lot of medical information and we feel we have digitalized and made available everything at a fingertip. But how to streamline that responsibly? We found a big infodemic and so much of uncredible and false information roaming around in the pandemic, which caused a lot of distress to a lot of doctors also and a lot of patients also. So I think this is one need gap I perceive, that there have to be interactive digital platforms for credible and relevant medical information and guidance to improve the health awareness and access. The second aspect that I'll talk about is building the base of Indian healthcare. So Dr. Malti had also talked about the patient-centric approach. We are a very disease-centric approach so far in treatment. We are about treating the illness, treating a disease. But I think the pandemic has thrown this on our faces, that we need to have a patient-centric, holistic approach to both prevention and treatment. It's about the person and not about the disease. And the same disease presented differently in different people, and they responded differently to the same treatment. So we cannot be treating lab reports, treating the disease, or treating a virus. We need to be treating the person holistically. So building that base of healthcare, I feel, is the second aspect I'd like to talk about. The third, I think, again, collaboration and combination. So we have come this far with multiple aspects in our healthcare system, which I just highlighted to you. We have medical practitioners who are specialists. We have medical practitioners who are in indigenous system, those who are general practitioners, family physicians. We have healthcare establishments ranging from private to public to peripheral to urban. We have pharmaceuticals and pharmacies, allied health, and of course, to integrate all this on a common platform, the information technology industry has to come together. So in the third aspect of digital healthcare, I see this collaboration and combination as a very important aspect. And finally, the data analysis. I think India is sitting on a treasure house of data. And if you see globally, we contribute very little to global healthcare data. and we have the maximum to offer. So I think the clinical research, epidemiology, real world evidence, all leading to big data analysis is the fourth important part of digital healthcare that can improve insights, that can improve evidence-based medicine. So coming to the first aspect that I talked about, awareness and access. So of course, our growth, India's internet penetration is currently at 40%, but 87% of that are regular users. Now, the interesting part is even in rural India, nearly 200 million internet users are there today. So the penetration of the internet has been really deep, and being part of Asia, we contribute to 50% of the world's population, and all information today is available to the patient at the fingertip, which is good and which is bad too. So that is a double-edged sword that we are dealing with, and I think doctors are at the receiving end of this infodemic in a very big way. So important thing is empowerment. We need to empower the patient, empower the people. And empowerment doesn't come with information, which is available to everybody. Empowerment comes from the right information and awareness, that information leading to awareness, and the information being relevant and conveniently accessible. So there is a huge digital responsibility that comes with the health information which is there through digital means available to the patients. So need of the hour, I see a huge innovation scope over here, is building digital health information and guidance platforms. And that is where I have humbly tried to do the same during the pandemic. Dr. Varsha's Health Solutions is an health information and guidance platform, where we have tried to, our endeavor has been to make the information credible, verified, and from a qualified source. So it's coming directly from a doctor's face, from a doctor's table, and it is regularly updated. There is easy access, it is open to all. It has to be linguistically relatable. So we may be, really technologically advanced in digitalization, but it has to be linguistically relatable in a country like ours. It has to be simplified and understandable. So if you find a lot of medical information on the digital platforms, mostly the common man can't even digest it, or he interprets it wrongly or gets the totally wrong tale of it. So it has to be simplified and understandable for a common man. It has to cater to the socio-cultural and educational diversity. So we have education levels from the illiterate to, all kinds of education levels, and our socio-cultural diversity is the maximum in the world. So we have to have digital health information platforms that are catering to the socio-cultural and education diversity. And these health information platforms have to be interactive. I find very few are, and a patient can't even put in a query or ask a question or request for some particular information. So they have to be interactive and engaging with a guidance feasibility inbuilt into it. And finally, all these health awareness and information platforms have to translate into enhanced public health awareness. So this is the first aspect I want to highlight as the A of digital health solutions, that the awareness and access to health information, which is humongous right now, is a double-edged sword, and it has to be made useful for public health awareness. Therefore, the platforms have to be innovative, coming from credible sources, and having a socio-cultural, linguistic, educational, as well as interactive relevance. Coming to my second aspect is building the base of healthcare. Now, being a family physician myself, practicing holistic health, I have been treating a lot of patients in home care during the COVID pandemic, and these are some of the learnings that I want to put forward to you from the pandemic. Firstly, the importance of holistic health and wellness. I think it has not come forth better than this during the COVID pandemic. The person and family-centric approach. This was probably the first time that we treated families who were at different stages of disease, manifested differently, had different comorbidities, different age groups, manifested different symptoms, and had different kinds of post-COVID or long-term rehabilitation challenges. So we were treating families, treating people, and not treating the disease. The disease was the same, but it was so different in different people. So the person-family-centric approach has come through as a learning from the pandemic. The fact that family physicians and GPs managed more than 90% of the patients in home care. I think this is such a big digital revolution, because what we really heard of on television or in newspapers was from specialists and hospitals. We never heard from the family physicians. We never heard from those who managed 90% of the patients in home care. And that was done entirely by telemedicine and digital consultation. And it was such a huge thing for the health economy, because it took away a very big load on the healthcare infrastructure. And this is something that needs to be further developed. The entire monitoring, rehabilitation, long-term follow-up, including the control and management of comorbidities, which determined the prognosis and recovery in a lot of patients, was done digitally. So this was the base of healthcare, with the family physician and the digital management of patients, that needs to be further strengthened at its foundation, so that it becomes the way of healthcare and the health infrastructure becomes really firm at its base. Now, holistic and preventive health, I think, has come forward in a big way, and the digital technologies that are available to us today have to focus on further enhancing these 5 pillars. So digitalization should not take away from holistic wellness. And these are the 5 pillars that, as family physicians, we were constantly emphasizing through our digital means, whether it was through online monitoring or whether it was through the digital telemedicine, WhatsApp, video calling. So we kept stressing on these 5 pillars of holistic and preventive health. And the second aspect that we really emphasized was the management of comorbidities. So this needs a constant touch point, which is very difficult for the patient to keep coming to the doctor. So managing comorbidities has to be seamless, it has to be continuous. And we saw that all those people who had their comorbidities well managed and controlled fared far better during the pandemic. And this was the game changer in patient management and patient outcomes. So digital technology has to be evolving more and more, so that there is a seamless control of these comorbidities. So I think one of the greatest innovations was health apps. A lot of them have come in, right from monitoring all your wellness aspects. So you can monitor your sleep, you can monitor your diet, your caloric intake, your nutritional quantity and quality of your diet, your physical exercise, how much is the calories are being utilized, or how much relaxation time is being given, how much time is being set aside for your hobbies or your family time. So you can create an entire wellness app. And I think this is one of the most beautiful innovations, that a human being can now monitor his wellness and can make sure that he is leading a life which is holistic and which caters to holistic health and wellness. And these apps have been very useful for that. And apps have also helped in control and management of the comorbidities, that is monitoring your hypertension, diabetes, or any kind of CKD, COPD. All these were, self-monitoring of glucose, as Dr. Madhukar and Malati mentioned, and also many other aspects of comorbidities could be monitored through these health apps. So I think this is something that has a lot of scope, and I'm hoping that Dr. Naveen is going to talk to his students on more of these holistic health and wellness apps, which can help a person monitor his daily routine and make sure that it is healthy. Now, this is a small topic that I want to put forward, which is close to my heart, because I think this is the foundation of Indian healthcare, the family physician. And in India, we don't have the concept at all, unfortunately. We have GPs, we have, practitioners who do general practice, but the family physician goes beyond a general practitioner. And a family physician takes care of the physical health and primary care, mental health, is well versed with socio-cultural and occupational factors, public health aspects, lifestyle and diet, economical aspects, as well as the family history. So the family physician has to become the face of digitalization of India, because the family physician is the one who's going to treat all the age groups, the comfort and familiarity, proximity and accessibility, the person-centric and holistic approach. He can impart the health awareness, information, guidance, and do effective monitoring and follow-up, and is the link for timely referral and specialist care. And going through a family physician to specialist care has shown worldwide to have better patient outcomes than going to specialists directly, because of the amount of information in terms of understanding the patient and the patient-centric approach that can be done by the family physician. So it is important that the family physician is empowered with digital technology. And if that is done, the entire foundation of healthcare system in India can be built very effectively. So digitalization has to happen in the first aspect of training general practitioners and our colleagues from alternative and indigenous systems of medicine, training them into becoming family physicians and integrating all these systems of medicine and orienting them towards family medicine and holistic health. So digital technology can play an amazing role here. And it can also help to improve the number and distribution of FPs in rural healthcare through digital platforms. So if we have digitalization at the level of the family physician, we can improve the equitability of healthcare and the distribution of family physicians, certainly in areas where we have a huge lacuna of healthcare and physicians. And the digitalization can be the main source of continued medical education, updating guidelines and standard practices for the GPs and FPs, and of course, help in the digital health records. Now, we have hospitals who have been brought towards electronic health records and digital health records very well. But at the level of individual family physician clinics, we are still facing that problem, and digitalization needs to come at that level. And digital medicine will be this way of a structured referral system also in medical practice. So if the digital system of referral can come in from a family physician to the specialist, it can be an amazing way of streamlining not only medical practice, but patient care. And the digital the digital platform needs to be created for sharing experiences and insights of family physicians. And there should be local digital platforms, maybe for one area in a big city, where they can all interact with each other. And we had created one such platform, which was called the Mission Mumbai COVID Care. And this was all the family physicians on one digital platform where we kept sharing experiences of treating COVID patients in home care, and that helped us greatly in interaction and improving the patient outcomes. I'd like to add a word here that the Ayushman Bharat, Dr. Malti had mentioned about ABPMJ, but they have also launched a lot of health and wellness centers, which has holistic health combined with telemedicine facilities. I think this has been one of the greatest digital moves by the government, where they have combined personalized holistic medicine with digitalization and digital solutions. And we have several such centers now opening up in all parts of India. And this could be one of the key game changers for the foundation of healthcare and promoting holistic health and family medicine. This is just some data which I am sharing with you of managing all COVID patients during the 2021 Delta wave, so entirely digitally. So we managed all these patients in home care completely digitally, monitored them, managed their comorbidities. We streamlined them in their second week and decided triage of how to treat them, whether steroid intervention was required or where they required oxygen support, who required hospitalization, completely done by digital means, and we were happy to publish this data. And another data that I'm showing is how we managed families in COVID care. So this was a family case study where entirely digitally, right from the child to the adult and the elderly in the house was done digitally. And we also did we merged multiple aspects of healthcare. So things like not having a common kitchen available. We were able to fuse food services, fuse social services where a child had to be taken care of for a parent hospitalized. We fused the diet management. We had proning and breathing techniques through digital means. We were able to give psychological counseling and stress management. We were able to also disseminate hygiene guidelines, sanitation guidelines, and all this by avoiding over-medication. We did it by fusing multiple digital platforms all through. It was done entirely remotely, and we were able to provide good care to all these families and patients during the very, very deadly Delta wave in April, May 2021. The third aspect that is actually like a dream for me is the collaboration. I think India has such intelligent industries. We are amazing when it comes to coming together as a family or coming together as a society. So I think collaboration can come on so many fronts. So right now we have a lot of individual apps available. We have a pharmacy app, we have an app for an ambulance, we have an app for insurance, we have an app for hospital beds, but we need to create a health ecosystem platform. And again, I'm going to beckon to Dr. Naveen because he has a lot of students who are doing innovation in healthcare. So to come up with a health ecosystem platform where we are able to bring together medical practitioners, health establishments, pharmaceuticals and pharmacies, allied health services like ambulances or oxygen facilities or home ICUs or wheelchairs, the health insurance that needs to come on the same platform, because a lot of patients get so inconvenienced by merging their health insurance with their illness when they're already in such a distressed situation. Social services, the food and nutrition industry, all this needs to be one health ecosystem on a single application, which the information technology needs to come up with an amazing innovation. I think here there is amazing scope for innovation. And already we are seeing Ayushman ABPMJ, which is, I think, the first of its kind collaboration between government and private nursing homes and hospitals done entirely digitally online. So the private hospitals are able to, make use of a government insurance, which is so beautiful, very wonderful collaboration. We have a lot of, these medicine delivery apps individually. We've had the vaccination app, we have COVID beds app, we have insurance apps separately, we have nutrition apps separately, we have, health aspect services apps. So if all this could be one, we have one health ecosystem app where the patient can, if he has a condition, he knows the drugs will come, the hospital bed can be arranged, the food services can be arranged, the insurance can be arranged. So that is, I think, the ultimate that we can get in building the health ecosystem with a firm foundation with our family physicians. Finally, the D, I've covered the ABC, so I'm just coming to the D. I think we need so much here in big data and real world evidence. I think India tops the world in real world evidence. We have so much data which is there, but unfortunately never analyzed, not streamlined, and never makes it to a Lancet or a BMJ. We want the data from the 90% of family physicians to make it out there, because that can change the face of how we look at diseases, how we manage diseases, and that can happen, help us understand disease patterns. If we have the data of the entire family physicians, general practitioners analyzed on a regular basis through big data analysis, we will know epidemiological trends, patient risk, predispositions, our seasonal and regional variations, comorbidity associations, and treatment responses, which can really improve our disease prediction, management, prevention, symptom recognition, predicting prognosis, complications. And it has been seen that big data analytics can reduce hospital and clinic costs by 25% over 5 years. So it can be a huge contribution to the health economy as well as patient outcomes. So yes, we have made a lot of progress on cloud, on EMR, EHR, on on high security, AI-led healthcare, big data storage. However, it needs to reach our base. It's there at the apex. It's very well developed at the apex, but it needs to trickle down to the base, into small clinics, into family physicians, into alternate indigenous medicine, because they are the ones who are taking care of the majority of the population of our country. So we need to get that digitalization there and get their data out, which can completely change the face of how we look at medicine. And again, I'm very happy to be part of the National Health Authority and the National Digital Health Mission. This has been I think, the first of its kind digitalization approach, which goes down to the base of healthcare, and it improves collection, dissemination, storage, and retrieval. And as Dr. Malti again mentioned, the interoperability of healthcare systems and data. And it has streamlined and integrated all aspects of healthcare, from disease prevention, risk assessment, access to facilities, diagnosis, prescription, as well as availability of medicines through e-pharmacy, telemedicine, DigiDoctor, personal health records, as well as giving everything one health ID. So digital health, as I conclude, I would like to say two important aspects in my conclusion. Number one, digital health has to go to the base of healthcare. It cannot be a specialist and apex thing. It has to go to the foundation and base of healthcare, right from our primary healthcare centers to our general practitioners to our family physicians. And second thing that I want to highlight is it has to be a multi-collaborative effort. We have to build one huge digital healthcare ecosystem, which can bring together many, many aspects of healthcare, many diverse aspects of healthcare, and also empower all aspects of the society and the community towards better patient outcomes. So on that note, the digital revolution will take us towards our PM's dream of Atmanirbhar Bharat. And I would like to conclude my talk and thank you all for a very patient hearing. I welcome any questions.
Yeah.
Thank you, Dr. Varsal Narayan, for excellent presentation. And this covers all digital aspect of healthcare, particularly in India. I have a question to all the panelists, and the question is very simple, that for the benefit of masses, poorest of the poor, world over, not in India, how can, there are three things, tell me three things, what we should do to reach to the masses with low cost healthcare. First, I will request Malti ji to address this issue.
Thank you.
With
Thank you
the
very
permission
much.
of chair.
Yeah, please, sir.
Yeah.
Thank you very much. I think it's a wonderful question, because that is the most important question that we need to answer at this point in time. How do we reach through the masses? Because high-end solutions definitely are available, but every one of them may not be easily reachable to the masses. So the best thing that has to be looked at, as I've always said, is there must be more ideas that should be incubated. Ideas that come from anybody and everybody. And as rightly said, that the moment we come with the ideas, the first thing is to say, is focus on this, we'll see it later. As very beautifully brought out by the Vice Chancellor, we shun them and send them away. So we are losing on very important inputs on this. So encouragement that should be given even at the school level. You don't have to wait to go up to the college level. There are children now who have come in the era of innovation. They are exposed to so much of the internet knowledge and the boom that they are unlike in the era earlier where you really did not have an access. I don't think you can come across anybody who starts walking not having a mobile. Because even a child you see of the parents taking in a pram into a supermarket, the child in the pram seems to be having one mobile in this. And I'm always looking, and when I'm buying a vegetable, I said, what is this little one who has not even started speaking, doing with the mobile? But he is or she is so, able to handle with the little fingers, just must have started moving the finger, but is able to move the app. So if that is the situation, even the school children, in fact, coming from the rural population, they should be the people giving ideas because they face the crunch of what they don't have. The best person to always give you ideas are those people who are facing the problem. Like we say, always the person who brings out the problem, ask them and say, what is the solution? So likewise, I would say that every child, whether it is a rural or the urban population, from the school has to have some time to talk, some time to be listened to say, what can we do? And that small ideas are what are going to make a difference. From there, you develop into any innovation that you want, make it on a large scale. The child might give you one small idea, but then the production, bringing it out, patenting, everything done can be done on a large scale. That is the first thing I would say is very, very important. The second thing that we need to focus on is probably the well-being of our population. That is extremely important. We do focus a lot on chronic diseases, on the oncology care, but sometimes it is probably just an anemia, a malnutrition, which is widespread. How do we reach the access? Bring about the apps that we are talking about. Can there be some simple ones that everybody can use and detect and say that I'm anemic, and all that you do is go and eat the greens. That's all. We don't have to look at a fersolate or an iron tablet at this point in time. What can you do? So that brings it up to the masses. The third important care, our focus should be in every digital technology should be preventive care. We need to move into an era of not treating diseases, but preventing diseases. We do a lot of research, which is absolutely essential, but more research into finding out how can you prevent, that is well-being. The more your population becomes healthy, more are they productive, and that will mean improvement in health economy. So all the devices which we make should be aimed at well-being and preventive health. These, I would say, sir, would be the three important things that I would say is the need of the hour. And from then on, we can just launch off into anything. Thank you, sir, for giving me an opportunity.
Thank you, Mr.
So I want to add one thing, sir, please. So along with this all explained by the Malti madam, the traditional medicine, the alternative medicine, that is also play a very important role. The Varsha madam has rightly said that the 70% general practitioners, they are in the urban area. Means our rural area still, that is, the doctors are not accessible, are not available, and specialists are not there. So in that case, our traditional medicine, our alternative medicine, that is definitely play an important role. Means the preventive or the holistic healthcare system, that is very, very important, has the important role to play.
Very well said.
Thank you, sir.
Very well said, sir.
Yeah. Thank
you.
I would like to add here, thank you so much, Dr. Naveen, for bringing that aspect out, because I think the key to effective digitalization and effective digital healthcare solutions in a country like India is that we strengthen the base of our healthcare, which is the general practitioners and the family physicians. Now, they are all over, like they are not just the allopathic strain, they're also the indigenous systems and alternative systems of medicines, which take care of such a huge population in the periphery. So if we are able to strengthen this layer of healthcare with our digital solutions, I think we would have built the foundation that we are looking for. Because a lot of our digital solutions are probably not reaching this layer. And when we found that this layer was digitally empowered during the pandemic, how much of patient care could happen at their level, taking off the load from the main health infrastructure. So I think this particular layer has to be our foundation, and we have to empower them. So we can digitally empower them in 3 ways. Number one, train them digitally. That is, get them all on one platform and train them towards being family medicine practitioners, towards holistic health, so that they can be the voice to improve health awareness in the population. Because they are the ones who are going to be, dealing with patients, and a patient is always comfortable with Mera doctor, my doctor. When he gets very intimidated when he goes to a doctor he doesn't know. But when it's my doctor, my neighborhood doctor, the effectiveness of imparting health awareness and effective holistic health and wellness improves. So I think this layer has to be trained towards that, mindset. Secondly, the digital solution has to come to them in terms of telemedicine and online and remote management of patients. And I think our country has come up with the telemedicine guidelines very timely in 2020. Just I think we were a month into the pandemic, and the guidelines were formulated. So with the help of these guidelines, and most of the physicians don't even know these guidelines. So the guidelines on telemedicine and the way that this layer, the FPs and GPs can use telemedicine and video consult, online consult, remote consult, all these things, that will be the second layer of empowering them after training. And the third empowering we can do to them is their digital medical health records. Unfortunately, that is not being maintained so much at the clinic level of these FPs and, neighborhood roadside clinics. If that happens, the entire medical system will get so streamlined. Our referral system will also get amazingly streamlined. And we will be able to do the big data analysis and real world evidence in a very effective way. We'll become global contributors effectively of health data. So I think these 3 ways we can empower the foundation of our healthcare. And that, I think, would be the way to go further.
Thank you, Dr. Varshanarayan. Now I will have views from Dr. Madhukar also, please.
Definitely, sir. I highlight on most items communications and educations is very important. Now this year also is seen in children's like schools or colleges. We approach these people through the mobiles or online classes or even video conferencing, all these things. And also I just one point I want to mention. If a patient has want to give one example, if a patient has any chest pain in rural areas or any peripheries, so that time experts will be not available. Like if the patient has any chest pain, they have taken ECG also, so very difficult to read like these ECGs. So these situations like now digital innovations or communications, so this like apps also, it is an expert, not only would present at the periphery also, so they can give experts opinion on these things. So this is a simple one examples where we can reach to common patients or common peoples in the periphery through these digital innovations in health sectors, I think.
Thank you. Thank you.
Yes,
now over to Chairperson of the session, Mr. Naveen Seth. Dr. Naveen Seth.
So very first, thank you, Dr. Anil Garg, sir, for giving me an opportunity to chair the session. All the 3 experts, they have given very nicely the detailed presentation. Dr. Varsha, they given the complete Indian complex healthcare system, and very detailed ABCD of the future of the digital healthcare. Dr. Madhukar has given their observation, and Dr. Malati that very nicely covered all the topics related with the health economy and digital healthcare system. Uh, so most of the points were covered by all the experts. And Dr. Barsha rightly said that in our India, even though there is a digital system, this pandemic time, it is penetrated and there is total transformation. But still in our rural area, because the penetration of the net is only 54%. So still we have to work for the digital infrastructure. That is the important drawback of our country, and government is taken a number of initiatives for the creating the platform at all level, and so many healthcare initiative taken by the government of India, Ayushman Bharat, healthcare mission, various programs, the Pradhan Mantri Jan Aushadhi scheme, and so many schemes. But still, the data network collaboration, that is one of the drawback in our country. Data were scattered, so every time patient has to move with the files and other thing to take the reports every time. So that is the major drawback, because the data is not centralized in a card, but government has taken the initiative, and slowly we are towards that data analysis and data network. Uh, so thank you very much for giving me an opportunity to chair the session. Thank you.
Thank you, Dr. Naveen, for excellently chairing the session with the bottom-up approach. And Dr. Malti, Dr. Varshanarayan, and Dr. Madhukar for giving different color to this digital healthcare conference. Hopefully next year in person, this digitization will be discussed, and we will invite you on 12th and 13th of April next year, before 14th. Okay, so 12th and 13th of April, we will invite you, and hopefully the speakers from various places, they will ask question in present form, in person form. Thank you very much for your excellent contribution. Thank you very much.
Thank you. Thank you for the opportunity.
Thank you.
Thank you.
Thank you.
Hello, good morning, good afternoon, good evening. Hello, hello.
Hello.
Hello, good evening.
Dr. Gupta, welcome.
Good evening, sir.
It is always pleasure to have you here.
Thank you, sir. Thank you so much, sir. Thank you.
Always. We will start within the next 5 minutes.
Hello, Miss Aishwarya. Hello. Welcome, Dr. Hari Prasad.
Thank you. Good to be on the platform.
Can we start the session?
I'm not sure. I haven't heard from the organizers yet.
Yes, sir. So we will start. We have other co-panelists. So please, we will start within minutes.
You can start, or will there be an introduction, or we just go start?
Yeah, we will start within a minute.
Sorry?
Yeah, we will start within a 1 minute.
Okay, no problem.
Welcome, Dr. Prasad, and
Thank you.
congratulations for the excellent award.
Thank you, Dr. Anil. Thank you so much. A privilege.
We will start within a minute.
Sure.
Welcome to plenary session 5, personalized, preventive, precision, and emergency medicines, PPPM. So I hand over to Honorable Chairperson, Dr. K. Harin Prasad, President, Hospital Division, Apollo Hospitals Enterprises Limited. Dr. Hari Prasad got global award this morning, so I have to congratulate and request him to chair the session and steer it. Thank you.
Thank you so much, Dr. Anil, and it was a privilege receiving the award, and I truly believe that it was an award for all the healthcare workers across the world, especially in the pandemic. And congratulations for hosting the World Health Conference with the theme of Global Transformation in Healthcare. And the topic given has been 3 P's and 1 E. But I strongly believe the global transformation is going to be 6 P's and 1 E. So 1 is preventive healthcare, and prevention is absolutely a must. And I don't think there can be a bigger example of the need for preventive healthcare than the pandemic itself. Nothing could keep us at home, but the pandemic did keep us behind locked doors, and people were hesitant to come out, all to prevent contracting the virus. So, and NCDs, non-communicable diseases, especially in this part of the world, are going to become a major factor. And the pandemic is actually adding to the disease load of the non-communicable diseases. And all these non-communicable diseases are lifestyle diseases and are preventable. So preventive healthcare is going to be a major part of the future of healthcare. And the second part of it is proactive. So far, the community has been laid back in terms of healthcare. We used to see people coming in the later stages of the disease. You take oncology, they used to come in stage 3, stage 4, where they used to spend more money, more morbidity, less, poorer outcomes. But we're going to see people who are going to be more proactive, healthcare systems which are going to be more proactive in reaching out to the community, and the community reaching out to the healthcare system also is going to enhance significantly. And I think that's going to be a significant transformation in healthcare for the future. Then personalized is something which I believe is going to become a big thing in the future. Now that we've started understanding the disease much better, even to the genetic and molecular level, and we believe very strongly that no two individuals are the same, and in the medical profession, all of us know that the same drug for the same disease works in two different manners, and every individual is different. So we, for sure, are going to get into more and more personalized medicine. And I can give you an example. A preventive health check so far has been a battery of investigations followed by a consultation. But now we've got AI algorithm, machine learning and AI tools to identify what are the right tests for an individual, for that individual person, so that we could focus on that, only get those investigations done and get a personalized health check done for that individual, which is definitely going to be more efficient with better outcomes. Similarly, the next P is precision, with more improvement in the surgical skills or the human skills, better technology availability, better biotechnology. We are able to do things with much more precision. Robotic surgery is a great example of enhanced precision in healthcare. And I think that's the direction healthcare is already started taking. And we will see a lot more in the future in terms of precision in healthcare. And one more P is perseverance. What the pandemic has taught us is that we need to be, consistent, we need to be patient, and we need to persevere with our efforts in handling a situation, in handling a pandemic, in handling an epidemic, or I believe that non-communicable diseases are of an epidemic proportion at this point of time. So perseverance is something which is very important. Human nature is such that we tend to focus on what's happening right now and forget it about the next day about it and get into a new thing. So I think perseverance in healthcare is going to bring about a lot of transformation in the future. And the last P, which I'm going to talk about, is partnerships. We've seen that healthcare is universal. We've seen the COVID, which from one small town in a country going across the world and creating havoc across the world. So it is not going to be anymore my hospital, my clinic, or my drug, or my technology. It's all going to be about partnerships. It's going to be public, private, and policy, and most importantly, people partnership is going to be the future of healthcare, where people are going to drive the healthcare, which has to be a combination, a partnership, true partnership between the government sector and the private sector. And we've seen it happening to an extent during the pandemic, and I believe that it is only going to be enhanced if we are going to look anyway, if we are going to go anyway close to universal healthcare in the future. And we've seen during the pandemic, people, the number of the utility of hospital beds have come down. The need for hospital beds have come down. It's not just because of the pandemic. Then if you look at, let's say, any surgical procedure, a patient used to stay in the hospital for 7-10 days, but now it's a daycare surgery. Patient comes in the morning, goes off in the evening. We're doing a knee replacement surgery daycare. We're doing let's say an angioplasty daycare. So multiple procedures have become daycare, and the need for hospitalization has come down. And I believe that in the future, the number of beds is going to become irrelevant, except in an emergency. Emergency is something which a person has to come into an hospital, and emergency services, again, have all the other P's which I have spoken about. They need to be precise, they need to be proactive, they need to be efficient, and they have to make sure that the best use of the golden hour is made during the emergency. So hospitals and beds are going to become very, very relevant in the future in the emergency. And the NCDs, the non-communicable diseases, whether it's a heart attack, whether it's a stroke, whatever, they're going to result in many, many more emergencies. And we've seen in the recent past, young, active, exercising individuals just dropping dead. We've seen many celebrities who have been spoken about, and I'm sure the many others who are not celebrities also faced a similar situation. So I think emergency is going to become a big, big thing in the future. And I'm very pleased to have a very distinguished international panel to speak on the during this session. And I thank each one of them for taking time off and spending this time with the participants. I would like to first request Dr. Sergey, who is a professor in immunology and medicine in Russia, to start the panel. Dr. Sergey, over to you.
Good evening, good day. Just a question. May I ask you to help me to share the presentation? How to do it?
If you see at the bottom of your screen, there is a button called Share Screen.
At the bottom half of your screen, sir.
You mean the green one? Green
Yes,
one.
that's right. That's right.
Yes,
the
sir.
green one, you press on.
I
there
would
and you can-
push it. Push, and then okay. One moment.
Yeah, now we
Do
can
you-
see your
Do
screen.
you
You can
see
do.
the presentation
Yes, we can see the
Yes, sir.
presentation. Go ahead.
or not yet?
No, we can see it. Go ahead.
Sir, go ahead, but you need to make it full screen, sir.
One
Maybe it's-
moment. I mean,
The presentation mode.
Go into the slideshow mode.
yeah. How do it? One
F5.
moment.
Press F5.
So you can also press F5 and it would be full screen.
Yeah, I see, but I cannot find it.
No, press F5 on your keypad.
Keyboard,
Press
sir.
F5.
F5. F.
On the top part of your keyboard, you'd be able to
Oh,
see the
okay.
F.
Okay. Do you see it?
No, it's still not yet in the slideshow, but for want of time, I think we should move on. Because
For me,
we're not
the
able
whole
to help you
screen-
further. The reason being, it's in Russian. Your screen is in Russian, and we're not able to really help you on that because we can't make that out.
For me, the whole screen.
Now, can you go to the leftmost button on your screen or your rightmost button and click on it?
So even if it is not on the full screen mode yet, we can see the slides. So perhaps we can
Yeah,
go
press
ahead.
that, please.
Just click the fit to window.
Okay. May I start?
Yeah, please go
Front
ahead.
of, in the
Please go
top
ahead,
of the
please go ahead.
center, you see fit of the window.
For me, technically virgin.
So there is a zoom button presentation. You go into
Yeah.
the view, and there is a fit to window button. Click. Just click here. On your presentation, just scroll the mouse.
Okay, for want of time, you can go ahead. We can still see your
You can
screen.
see it's okay.
You can go ahead.
Please go ahead.
No, we lost it. You need to present the share screen button again.
Do you see or
No.
not?
No, please press
Yes.
the share screen.
You need to go to that button on the bottom half of your laptop and click on the share screen button that you had done earlier.
Green one.
Yeah, the green button. Yes, sir, we can
Yeah.
see it now. Yes.
Okay, that's it. That's
Okay,
it.
go ahead. Please go ahead.
Please go
Okay,
ahead.
thank you. Let me share with you some issues unveiling the impact and role of some special molecular tools to be involved into clinical practice of a physician or general practitioners who are operating with the achievements and innovation coming from the upgraded model of healthcare services, I mean personalized precision medicine. Today, I have stressed the practical, clinically valuable role of antibody proteases as the newest molecular tools of the next step generation, being biomarker to be applied for nanodesign and translational application used by physicians today. The implementation of diagnostic, predictive prognostic as applicable to PPM, personalized precision medicine biomarkers, remains the holy gate, the holy grail of platforms, algorithms, and protocols, which are the crucial for personalized and precision medicine to be developed further. So it's necessary to identify biomarkers of the newer generations and to create simultaneously a fundamentally new strategy based upon subclinical and predictive recognition of those biomarkers long before the disease clinically manifests itself. Among the best validated predictive biomarkers are autoimmunity related ones to predict risks of the chronification and thus disabling, since chronic autoimmune disease as being a sort of chronic inflammation are preceded by a long subclinical, so-called symptom-free phase. Just look at the diagram illustrating a stepwise diagram of chronic diseases, including the subclinical cryptic latency. It's just a scope of most valuable autoimmunity related biomarkers cited in Yehuda Schoenfeld publications. I mean, Yehuda Schoenfeld from Israel. For example, multiple sclerosis as a kind of chronic autoimmunity related conditions is considered to be just one of the chronic autoimmune diseases resulting in a destruction of myelin by different tools, including canonical autoantibodies. It's just the diagram illustrating the pathogenesis model of MS, including the primary damage. It's just a scope of all anti-myelin antibodies as a key biomarkers and biopredictors of demyelination. The crucial step in the pathogenesis of MS, I mean multiple sclerosis, as a kind of chronic autoimmune inflammation, multi-step, is a primary myelin damage which is mediated by autoantibodies. At present, a spectrum of myelin-associated autoantibodies occurring in MS patients has been confirmed to be very large and valuable. Along with canonical antibodies, some of the families proven to occur are antibodies possessing with the catalytic activities. Catalytic antibodies or enzymes. Enzymes mean AB, antibody, zymes, enzymes, and thus to belong to antibodies with a principally new feature, functionality.
Can you move your slides?
Sorry?
Can you move your slides?
Would you say that again, please?
Yeah, can you change your slides? Can you next?
Yeah.
Yeah, please.
The first catalytic antibodies vasoactive peptide anti-VIP catalytic antibodies binds a 7 amino acid subsequence of VIP distant from the cutting edge. This is the first discovery of the history of catalytic antibodies. Antibodies like antibody proteases detectable in chronic autoimmune myocarditis resulting in to cleave cardiac myosin, or in autoimmune thyroiditis to cleave thyroid autoantigens as the major cardiac and thyroid autoantigens respectively, and thus informative biomarkers to monitor the chronic courses. Look, it's just an example of illustration of antibody-mediated hydrolysis. Wow, disappeared. One moment. Okay.
Yeah, go ahead. We can see it perfectly now.
Okay. This is an example of antibody-mediated hydrolysis of allergenic thyroid globulin and the TPO in chronic thyroid autoimmunity conditions. Well,
please go ahead.
yeah, but no going ahead. I push, but no. Okay. A situation of much greater interest is occurred in MS, multiple sclerosis, which is a chronic autoimmune inflammation in central nervous system, CNS, and resulting in demyelation, axon loss, and development of disability finally. We have established in sera of MS patients and mice with experimental autoimmune encephalomyelitis, EAE, that they exhibited MBP, myelin basic protein, specific proteolytic cleavage of the MBP targeting molecule. It's just the illustration. We have found that in MS patients' sera, antibody proteases is about 70% exhibited highly active antibody proteases as compared with the controls. I mean, healthy controls. Look, the most active antibody MBP targeted antibody proteases, most active in exacerbation, in remittent phase, in progression phase, in secondary progression and primary progression phases. You see it's indicated in red. Antibody proteases due to Kurtsky expanded disability status scale is mostly active in the mostly aggressive form. What about the value? Sequence specificity of antibody proteases is so much valuable. So you will see now that among 1, 2, 3, 4, 5, among 5 sequence sites within MBP molecule, those 5 sequences are dominant, which are being attacked by antibody proteases, I mean MBP targeted antibody proteases, withdrawn obtained from MS patients' sera. Very interestingly, most of those sequence-specific sites at a set defined are located within 43,170 region of MBP, which are just immunodominant. 2 sites from the set located within 43,170 subsite sequence would comprise 2 other subsites, subsequences that, whilst being sequence-specific, highly immunogenic and encephalitogentic both as well, proved to be specific and major inducers of very aggressive EAE in special line mice. Moreover, both subsequences have been proven to be major MBP targets to be attacked by antibody proteases obtained from patients with secondary progression causes of MS, progression phase, and with remittent course of MS, exacerbation phase. Both are aggressive phases. All of those immunogenic, encephalitogentic sites of immunodominant category responsible for generating aggressive bursts of demyelination are concentrated in 3 major areas of MBP molecule. The strongest one is in the smallest sequence. Weaker epitope is formed by a little bit longer subsequence. A site with the lowest immunogenic and encephalogenic properties is formed by a rather long sequence defined. What about the evolution of antibody-associated proteolytic activity at different stages of the disease progression? For those purposes, we have been monitoring MS patients, their direct relatives, and healthy voluntaries for around 3-4 years. Look, apart from MS patients, where antibody proteases are highly active with and where the diagnosis has been confirmed, 2/3 and 1/5 of the relatives were initially seropositive for anti-MBP autoantibodies with no proteolytic activity, so-called disarmed antibodies, and MBP specific but low active antibody proteases respectively. Neither of those seropositive relatives, regardless to type of antibodies, demonstrated neither clinical manifestations nor instrumental or laboratory signs of multiple sclerosis. Patients being seropositive for antibody proteases were being monitored for a long time whilst demonstrating a stable, stepwise, but a stable growth of MBP-targeted antibody-associated proteolytic activity when we're being under the study. Look, 2/3 of the relatives being seropositive for antibody proteases monitored for 2-3 years have been demonstrating stable growth of MBP-targeted antibody-associated proteolytic activity during the time span when we're being under the study. Look, the evolution of antibody-associated proteolytic activity started at the subclinical and then transformed into clinical courses of MS, multiple sclerosis, progression. A substantial proportions, around 30% of relatives demonstrating initially low active antibody proteases with no trends to grow, have had subclinical evidence of latent, hidden autoimmunity without developing clinical avert disease. Look at the evolution of antibody-targeted, antibody-associated proteolytic activity. Look, initially, this is just in average at MS patients. Initially, only 3 units, and then stepwise growth in 6 months, in a year, in a year, in 2 years, in 3 years, as compared to healthy control. The immune escalation, illustrating reorienting of the sequence specificity, send it more important targeted sites for proteolysis might be an early or even pre-early prognostic and predictive sign of progressing demyelination and thus the clinical illness to come. Sorry. The regular canonical autoantibodies play neither predictive nor discriminative role to affect the clinical, subclinical stage of MS. Meanwhile, sequence-specific antibody proteases have proved to be greatly informative and thus valuable as biomarkers to monitor MS at both subclinical and clinical stages. Therefore, the proposed predictive value of MBP-targeted antibody proteases for the development of MS is being highly challenged. There is a great need in knowledge as applicable the rational design of new therapeutics to exploit the role of the key pathways in influencing the disease. In this sense, and in terms of personalized precision medicine, antibody proteases can be programmed and reprogrammed to suit the needs of the body metabolism, or could be designed for the development of principally new catalysts with no natural counterparts. And we have just started doing it with 3 international companies, 1 in US and 2 in Germany. Of great importance, antibody proteases directly affecting the physiological remodeling of tissues with multi-level architecture, for instance, myelin. Further studies on antibody-mediated MBP degradation and other targeted antibody-mediated proteolysis may provide biomarkers of next step generations and thus a supplementary tool for assessing the disease progression and predicting disability of the patients and even persons at risk. Thank you so much for your patience. Would be much happy to share with you the issues of our research and the designed outcome in any kinds of the future to come. Thank you so much again.
Thank you, Dr. Sergey. I think you're doing some really great work. and trying to identify solutions for problems which don't exist now. And thank you for sharing your research work. I'm sure the viewers would be benefited immensely and would be convinced that there is light at the end of the tunnel. From Russia, we now move to Egypt. We have Dr. Meena T. Kelani, who is a professor at Minya University, and she'll be sharing her views on personalized, preventive, precision, and emergency medicine. Over to Dr. Meena. No, you're on mute, Dr. Meena. Can you unmute yourself? There's a button on the left side of your screen, which is like a mic. You need to press on that. Can somebody from the Secretariat unmute him, please? You need to unmute yourself, Dr. Meena.
Dr. Meena, on left side, there is a speaker button. You have to just click on that.
Yeah. Go ahead, Dr. Meena, please. So you again click the button again. Now you're fine. Yeah, yes, now you're fine.
Thank you very much. Can you hear me?
Yeah. And you're sharing your screen also. Please go ahead with your presentation.
Okay. Well, thank you very much, Dr. Prasad. And I'm really very grateful for Dr. Antibody for the precious invitation. If you might please confirm that you can see the screen.
Yes, yes, absolutely.
Okay.
Yes, yes.
Okay. I will just make it full screen.
Yeah. I just want to remind you that the time is a constraint, and we would request you to.
I will go in a hurry. Yes, with pleasure. Okay. My topic today will be recent Western updates in COVID-19 pharmacotherapy. This is up to this day, April 15, and it is an Eastern Afro-Egyptian perspective. I'm Meena Kelani. I'm Assistant Professor at Pharmacology Department, College of Medicine, Minya University, Senior Consultant for Pharmacology Egyptian Medical Syndicate, and I'm also authors of Kelani's COVID-19 Immunomodulatory Protocol. So what is Kelani's protocol that we are comparing to the current Western guidelines to treat COVID-19 pharmacotherapy? The name Kelani protocol was published as it is in November 2021 at the highly reputable Inflammopharmacology. And here is a screenshot of this paper. It has been used safely and effectively to both by the traditional as well as the telemedicine to manage mild, moderate, and severe COVID-19 out and hospitalized pediatric, adult, geriatric, and pregnant patients since April 2020. Date of my first COVID publication. It is based on novel integrated pathophysiological and immunopharmacological approach to manage COVID-19. Myself, the author, has published 10 COVID-19 articles in journals indexed in PubMed. Many are Q1 and Q2 journals. Other COVID article published in International Medical Journal, but not indexed in PubMed. Yet, as well as several COVID preprints that unfortunately is being waited to be peer-reviewed because lack of available, as I believe, other honorable editors and or reviewers for months. I suggest it can end COVID-19. I've suggested this from April 2020. Can end COVID-19 immediately unless for undergoing corruption. It is very economic, and this is the reason that when I address many Western politicians and scientists, including that of UK, Canada, and elsewhere, they ignore it. I have official email receipts. They received it from June 2020, but no official response. Why? Because it is economic. This contradicts huge Western medical, financial, stakes with hundreds of billions of dollars, as well as I think racism. And it is not so weird to hear it. I'm proudly African, Eastern, and Egyptian, And I depend on India, Russia, and China to make it through that we can end this pandemic. By the way, this lady, if you can see it just beside me, she has been considered severe COVID-19. She was brought to me almost unconscious. She suffers from chronic hepatitis B. She has multiple risk factors. And in 3 days using Kellina's protocol, she was discharged on her foot. This is the day taken on the 1st of April. And today is the 18th day. She's at home. She's with her family. And I believe this lady would have been murdered in the West or any countries that follows the guidelines saying remdesivir and dexamethasone should treat this lady. No, remdesivir and dexamethasone killed hundreds of thousands of innocents like this lady that should have been with her family smiling and enjoying her life. So Dr. Prasad, at Apollo University, at Apollo Hospitals, I really wish you might consider Kellina protocol. It is the only protocol based on several published papers in highly reputable journals explaining why these drugs are effective, unlike the other expensive experimentals that got EUA with corruption, as I'm going to compare right now. But before, let's give a very fast idea how COVID-19 is still undergoing. New variants are coming everywhere to harvest more and more lives thanks to the corruption of USA FDA, as well as other Western agencies all over the world, as I believe and truly suggest. Most COVID-19 drugs, has only FDA EUA, emergency use authorization. But fortunately, some have been revoked even in this month. It is no surprise that updated COVID pharmacotherapy is very crucial for physicians all over the world to be aware of and use it cautiously in a personalized way to best manage our patients. So here is the COVID classification that I'm using. I call it integrated COVID classification. 80% of patients are suffering from mild or moderate symptoms. Yes, just fever, cough, dyspnea, and they usually recover from illness before progressing to the second or third phase. The second phase is called pulmonary phase, and the third is the most severe one, is called hyperinflammation or ARDS and other similar classification. 20% go to the second and third phases. They need oxygen supplementation, and severe COVID is usually defined when oxygen saturation is equal to or below 94%, and 5% develop to the cytokine storm or hyperinflammation, which is called critical COVID. This, according to many developing countries, affect from 15 to 25% of hospitalized patients, and this occurs in developing countries. I'm so fortunate since April 2020 till now, I have encountered many who are classified as severe COVID-19 and no mortality at all. Only mortality if they have already previously taken remdesivir, previously taken dexamethasone. But if Kellina protocol is given from the start, I believe this would abolish a lot of mortalities that could have been prevented. Patient with mild to moderate disease managed in the outpatient can progress to to severe disease, usually 7 days after the beginning of symptoms. Yes, this is true. I encountered so much. But there is another US advice which I consider very suspicious. They say SARS-CoV-2 may cause catastrophic illness in any patient, even among those without any risk factors. I'm telling you, no. This has only occurred because they use remdesivir, because they use dexamethasone and what they call severe COVID-19. And I explained in my papers why these drugs and other drugs are not causing any good. They are only causing harm, should have never received EUA for severe COVID. Dexamethasone might be used for critical, I think, yes, but for severe, I don't think, no. Remdesivir, I agree with the WHO that it should have never and should never be used for any COVID-19 patient, regardless of the classification. This is WHO official recommendation, and I believe many of you know this. Who are currently considered high-risk groups in the West? Almost everybody. I say it 5 Cs, 5 Ss, 2 Bs, 3 Is, almost everybody. If you see this huge classification, so everybody is high risk. So when you consider that high risk, now you should take Paxlovid. I also have a preprint saying Paxlovid will cause, like remdesivir has also caused new variants, new fatal variants that we might suffer huge consequences, like also molnupiravir. But fortunately, molnupiravir is considered the least right now to be recommended because it is well known it will cause mutations. So here is the summary of the most American or Western updates with an Egyptian perspective to be explained in just a few slides. For high-risk mild to moderate patient, use Paxlovid. This is the very choice nowadays. And my suggestion, there is an obvious outbalanced risk-benefit ratio when you compare it to Kellina's protocol. But of course, it will help to gain billions of dollars, no matter that as I suggested in a preprint, that many refuse to peer review. It will help evolution of more virulent and fatal variants. So what about, if not feasible, Paxlovid? Then they recommend high-titer convalescent plasma. By the way, just before a few days, they say you might use Paxlovid or sotrovimab, one of the monoclonal antibody. And I know for long that sotrovimab will not do anything better. So currently they just say, no, they revoke the EUA for sotrovimab and just only stick to Paxlovid. And I'm expecting just in few weeks, perhaps they will say, yes, use bebtelovimab, another monoclonal antibody bullshit, as I'm sorry to say it, but it is what I'm strongly saying, to help more and more virulent, variant to evolve. So if not feasible, high-titer convalescent plasma, they recommend, and I agree, it has a place. I think it is very good, and it is economic as well, but they prefer monoclonal antibodies for economic reasons. This is my suggestion. Only if high convalescent plasma, Paxlovid, and sooner bebtelovimab are not available, not working, then they say you might use currently bebtelovimab. Soon it will be first choice, as I know. And molnupiravir, my suggestion, this drug, like remdesivir, should have never received EUA unless Biden administration has invested $1 billion with Merck. So they need it. They need their money back, so they will distribute it to India, to Egypt, to whatever. But in USA, as many drugs, no, it will be lost, and I think they will not use it. It is well known, mutagenic, as well as I think Paxlovid also will help creation of more virulent. Here is some clinical pharmacology data about Paxlovid. It inhibits, yes, I think this Paxlovid might be used, but not in mild to moderate. So use it in severe, no, the results are not good. So don't use it at all. Don't use it in mild moderate that we have a really effective, real life protocols that can end this pandemic unless for the corruption. Ritonavir, for this reason, this Paxlovid has a lot of drug-drug interaction. It is not safe at all to be used for everybody. As Dr. Anils asked, we need some drugs for poor people, for poor patients. And another honorable Indian doctor said, yes, but we might also encourage considering new ideas. There is a protocol used from April 2020 with a lot of papers published to support it, but it is ignored because of Western corruption. And unfortunately, I have no support from my countries that is holding my promotion to associate professor for over 1 year. This is really fantasy. I hope India, Russia, and China might have a look at Kellina's protocol for the best sake of the rising soaring COVID-19 occurring in China as well as elsewhere. Here is some information, if you might go it, and the dose should be reduced in patients with eGFR above 30 and less than 60 milli per minute. It is contraindicated in severely reduced kidney function and contraindicated with numerous drugs. I'm a pharmacologist as well as a physician, so let me assure you that it is not safe at all to be used for all. It might be fatal, and they know it. But if you decide to use it, at least I recommend my fellow physician to use liverable COVID-19 drug interaction. It is free, available, and I used it many times. It is stressful. So my opinion again, evolution of virulent and resistant COVID variant is an existing treatment hazard for Paxlovid, and I highly recommend to reconsider its EUA for mild to moderate COVID. Monoclonal antibody treatment, they were first identified from convalescent plasma, but you know, some studies come saying convalescent plasma are not good. No, Low titer convalescent plasma are not good, but high titer are good, or as I do believe, as good as the very highly expensive monoclonal antibodies that makes billions and billions of dollars all over the world with nothing to give an added value if I compare it to Kellini's protocol. And here are some information about it. And for severe and critical COVID, no benefit and potential worse clinical outcome. And this is because of some phenomena called antibody-dependent enhancement, as I suggest in one of my published papers. But I suggest the greatest benefit of and I agree as well, the greatest benefit of monoclonal antibody is mainly in seronegative and immunocompromised patient when given within 7-10 days of symptoms onset. I also say they are well tolerated. I can't deny it, but high titer plasma are as equal and much more economic than this. Yet also risk of hypersensitivity reaction remain, as well as evolution of resistant variants. That's why I didn't use high titer convalescent plasma or monoclonal antibodies. I don't need it. I don't need them. And here are some examples that made billions of dollars for these antibodies. And the last one is to be revoked, the EUA revoked on April 5 is sotrovimab of GSK, and still, EvoShield. It is, by the way, it is not authorized to be used for treatment. It is only for pre-exposure prophylaxis, and there is a huge difference, by the way. And I think this one will be beptilovimab, the new one that will make billions and billions of dollars out of nothing. For convalescent plasma, let me assure, I agree again, it has a use in immunosuppressive diseases, those who are suffering from immunosuppressive diseases or receiving immunosuppressive drugs. And I suggest also this patient should be the only group that convalescent plasma should be also administered if Kellini protocols didn't work, but it worked for all patients, no exception at all since April 2020. It is much more economic than monoclonal antibodies, even after facilitating screening donors for the high titer to exclude the low titer. However, logistic restriction, I agree, are a big limitation, so Kellini protocol is enough. Well tolerated, again, risk hypersensitivity also remains, as well as evolution of resistant variants. Remdesivir, this is the most horrible drug that is heavily used in India, and I think this one has caused the Delta huge rise of this is the Delta variant that was a catastrophe, not only for India, but for the whole world. And they accuse India, no, they should accuse the American remdesivir, the Fauci remdesivir. And a lot of honorable physicians and scientists say this, but we are not here because the NIH bias for this failure, toxic drugs that was not beneficial for Ebola and used it for COVID-19 on bullshit drugs. Again, I must say it for the sake of millions who died because of this and other failure drugs. It is a blue drug. It was the first to receive an EUA in May 2020, and the first to be fully approved months later, just to tease the WHO, I believe. And here is an instruction to use it. I never use it. I will never use it. It is horrible drugs that should have never been used for humans. Toxicities include, among other, cardiac, renal, hepatic, hypokalemia, thrombocytopenia, hemorrhage. It killed lots of patients, telling it is COVID-19. No, it is not COVID-19. It is your remdesivir, Gilead remdesivir, Fauci remdesivir, and NIH remdesivir. It is only highly recommended by the NIH, the ones that cause this global catastrophe for all over the world, thanks to Fauci and his colleagues in the NIH and NIAID. Currently, unfortunately, several honorable guidelines now declassify remdesivir as of a choice for anything. Thus, just using for severe COVID-19, I am saying it is fatal in severe COVID-19. Don't use it. This is my opinion, agreeing with other honorable scientists from all over the world. And I'm very grateful to the WHO, at least for this part, because I heavily disagree with the WHO in lots of other things, including, of course, the vaccines. WHO recommendation after, and not only mRNA and DNA-based vaccines. I don't agree with them in their recommendation, but their recommendation for remdesivir is wonderful. Don't use it for any patient regardless of the disease. Since November 2020, this is an honorable recommendation. I highly recommend my fellow Indian physicians and scientists to revise the evidence using this drug. And molnupiravir is the first oral antiviral to be included. It, by the way, it works through lethal mutagenesis. It is a mutagenic by nature. So this molnupiravir should have never been EUA approved, but in USA it is considered the least to be recommended. But of course, in India, in Egypt, and other developing countries, it will be like the magic bullet, and it is nothing other than bullshit. Much lower efficacy result compared to other interventions. And the WHO recommend active monitoring of the drug safety. Perhaps it could be carcinogenic, as I published for its relative drug favipiravir in January 2021. Contraindicated for use in patients younger than 18, it is teratogenic. Not only pregnancy test is recommended for female if in doubt, moreover, sexually active male should avoid sexual intercourse or use a reliable contraception for at least 9 days since the start of therapy in order to avoid similar catastrophes. Again, I believe its EUA should have never been issued. An evolution of virulent resistant COVID variants is a potential real hazard. Here's Hippocrates. I think he's weeping right now, wherever he is. COVID is unfortunately not over yet due to several factors that lead to current and potential more virulent variants, which are evolving to evade our natural immunity as well as our medical intervention. Personalized medicine is crucial in management of COVID-19, and a unified prescriptions that occurs in Egypt as well as elsewhere. I think the blatant medical practice, at least, it should be considered a crime as well. And I've once learned that the most shameful act in medicine is to cause harm to a patient suffering from a self-limited disease. And unfortunately, they murdered hundreds of thousands of people that could have been treated with Scalability protocol since April 2020, using remdesivir, using dexamethasone, using other drugs that cause virulent variants as well as cause mortality, huge mortalities, then just simply accuse COVID-19. This is not the case at all. And let me give you finally one example of COVID malpractice in Egypt regarding this dexamethasone. This is the dose that should be used according to a recovery study that I criticized since day one and managed months later to publish my criticism at Stranger Nature Comprehensive Medical Medicine. In Egypt, it is something horrible. They use, for instance, methylprednisone. The dose should be 32 milligrams. In private and governmental Egyptian hospitals, they use methylprednisolone almost 200 milligrams per day. It is almost 10 times over the dose that should have been used. I don't know what else is occurring in other developing countries. The other physician just prescribe it to outpatient without severe. Lot of mortalities in young patients. I think from this heavy, severe malpractice, but they heard from the BBC that this is the magic bullet. No, this wasn't the magic bullet. This isn't the magic bullet. And the guidelines are being updated every day, and they will be updated. Sometimes in some hospitals, they give methylprednisolone 200 milligrams plus dexamethasone. So it was something very, very unfortunate. Killed a lot of young, healthy people saying it is COVID. No, it is not COVID again. It is USA, NIH, and FDA biased recommendation and corrupt guidelines. And here are my references, and you're most welcome to contact me.
Thank you, Dr. Thank you, Dr. Meena.
I appreciate it.
Thank you, Dr. Meena, and you very passionately put forward your personal view. And before welcoming the next panelist, I would like to just say that all the comments and the remarks made on this panel discussion are personal remarks and are not subscribed by the organizers or the other panelists. They should be considered as personal remarks and experiences.
Yes, perspective.
So
yes,
going from Russia, we went to Egypt and now to Dr. Dk Gupta, who is the Chairman and Managing Director of Felix Hospital. Over to you, Dr. Gupta.
Hi, good evening. Thank you so much. And I really congratulate Dr. Prasad for winning award. Thank you so much. And I would like, I think most of it has been discussed, and I would like to be very simple and straightforward, so that we should be talk relevant to the topic, and to talk in such a way that should be simplified for our layman also. Personalized, preventive, precision, and emergency medicine. We all know that personalized medicine, also known as personalized medicine, is a new frontier for healthcare, combining genomics, big data analytics, and population health. It's commonly referred as personalized medicine, is one of the most promising approach for tackling disease that have thus far eluded effective treatment, like cancer, neurodegenerative, or genetic disorders. There is a hope for these disorders because of this personalized or precision medicine. It is an emerging approach for disease treatment and preventions that takes into account individually variability in genes, environment, and lifestyle for each, and is specific to the person. What is preventive and personalized medicine? The new integrative concept in healthcare sector that enables to predict individual predisposition before onset of a disease, to provide targeted preventive measures, and create personalized treatment customized to the patient or customized to the specific person. If we talk about the example, we have already discussed COVID and other diseases, viral diseases. There are cancers can be treated because of with the use of this personalized treatment, like HER2 positive breast cancer cells. Tumor markers can be tested, and after these genetic or molecular diagnosis, we can precise our treatment, or we can target our treatment to treat the specific illness. Therefore, it is called a precision medicine. It is relatively new term, but we know that concept has been used in past for so many years, so many decades. Like we transfuse blood transfused to a selective person, after selecting donor specific to that group, and after cross matching. We do not infuse any random blood taken from a donor. It means we were using precision, but now precision, definition of precision is widened. We are using robotic surgery, we are using molecular technology, we are using biotech, we are using artificial intelligence to make it more precise. What is the importance of this precise medicine? It is about tailoring a treatment as individualized as disease. The approach relies on identifying genetic, epigenomic, and clinical information that allows a breakthrough in our understanding of how a person's unique genomic portfolio makes them vulnerable to a certain diseases. Therefore, it can be helpful in prevention, early diagnosis, screening, and in the treatment of a specific disease. What is the purpose of precision medicine? Precision medicine, also called personalized medicine, helps your doctor to find your unique disease risks and treatments that will work best for you. If we talk about the primary focus of personalized medicine, the goal of personalized precision medicine is to improve treatment outcomes, to improve diagnosis, to improve prognosis of treatment, and the reduce adverse effect or side effect that matters to both the clinician and the patients. What are the challenges of personalized medicine? We know that there is a limited knowledge, insufficient technologies, gaps in the research are major obstacles, and adding precision medicine to routine clinical care. Precision medicine has emerged in recent years as a potential way to deliver personalized, comprehensive care to patients with a wide range of diseases. So there is no major challenges or no major limitations to provide precision or specific medicine to a patient. How it is performed? It involves testing like DNA from the patient, genomes, tumors, testing the genome, the mutations, or the nucleotide. We have to go at blueprint level. And after that, we match which drug, which diagnosis which drug can be best suited for that patients. And after that, we start treatment according to the precise diagnosis or precise clinical pathology of that disease. Role of precision medicine in diagnostics, prevention and screening. Precision medicine helps healthcare providers find the treatment and medicines most likely to help a person. Using individual health information, they can run screening tests to look for early signs of a medical problem when someone has a high risk for that problem. How we are using it today? We are using it today to treat lung cancer, melanoma, colon cancer, pancreatic cancer, even in robotic surgeries, even in AI is used for diagnosis, even in treatment. It can also use in some rare conditions like cystic fibrosis and HIV, even like we have a promising result for this COVID also. Disadvantage of personalized medicine. The drawbacks of personalized medicine, for example, there are concerns that may not use this information in an ethical way. Even if the data or info can be leaked or it can be used in some other way, that can be harmful for the patient or that can be breach of the privacy of the patient. Also, if we have some data that can tell that this patient is predisposed or had high risk of developing such disease in future, then definitely insurance companies will have certain modified insurance policies for these patients. They will have to pay higher premium or they cannot be covered in the insurance also. What are the advantages of precision medicine? Wider ability of doctors to use patient's genetic and other molecular information as part of routine medical care. Improved ability to predict what treatment will work best for the specific patients. Better understanding of underlying mechanism by which various diseases occur. These were the advantages, and we know that in current scenario, everybody needs customized or personalized or precise medicine. They don't want side effects, they don't want adverse event, they want treatment at their home, and they want customized treatment at their home, even in hospital. They don't want to visit hospitals also. They want telemedicine, teleconsultation, video consultation. Only patient want to visit hospital for emergency care or maybe for surgery or daycare surgery. Means hospital will be irrelevant in the future. People will go for the emergency care or for the daycare or surgical procedures only, and that will be also a very of short step because of this precision or AI-based medicine. Future of personalized medicine. Technology like cheap genomic sequencing are enabling patients to receive entirely customized therapy based on their genetic, molecular, and metabolic makeup. Personalized medicine will both increase patients' outcomes and decrease side effects and unwanted complications. It offers a structured model for efficient healthcare. It is preventive, coordinated, and proven. It works best with network of electronic health records. We all know that everybody in even Government of India is working on digital health records that can be linked with the clinical and molecular information to make it easier to help patients and their physicians to make appropriate treatment decisions. What is the future of this precision medicine? Precision medicine offers tremendous opportunity to shape the future of healthcare. While it is currently most advanced in oncology, precision medicine also has wider, exciting applications beyond oncology and late-stage diseases such as in rare genetic diseases, also metabolic disorder, also even in viral insurance, surgery, also everywhere personalized precision will be required in healthcare, and it is now a future of healthcare. I think we are coming, we are on late schedule, so I would like to end my presentation here only, talk here only. Thank you so much. If you have any question, then I will help, ready to answer that.
Thank you, Dr. Gupta. It's so precise, and thank you for the wise words. And finally, we have Dr. Vijaya Padma, who is a professor of a very interesting and upcoming field, which is helping healthcare in a big way. Department of Biotechnology at Bharatiya University in Coimbatore. The floor is yours, Dr. Vijaya. You need to unmute yourself, Dr. Vijaya.
Yeah.
We can hear you now.
So first of all, I would like to thank the organizers for the opportunity given. I would like to present my So I'm Dr. Padma, Professor, Department of Biotechnology, Bharatiya University.
It would be nice if we can make it screen show, full screen.
Yeah. Okay, full screen, fine.
No, if you come down.
So my presentation.
Okay, go ahead. Yeah, now it's done. Yeah. Please go ahead.
So today I'm going to present my lecture on transformation in personalized medicine in this pandemic era, post-pandemic era. Just now, I think it is in continuation with the previous talk. Dr. Gupta was elaborating about the need for personalized medicine. Now we'll just go in brief why we should go for a personalized medicine in the which can be applied to this COVID situation. SARS-CoV, as all of us are aware, is a recently emerged zoonotic virus which has become a global threat to more than 200 countries, and leading to about 494.5 million confirmed cases and about 6 million deaths worldwide till date. Heterogeneity in SARS-CoV is one reason why it is very alarming. This is not caused, COVID-19 is not caused by a single virus, but a single RNA virus, but it's an evolving pathogen with multiple mutations, lineages, and variants. These variants are all identifiable through genetic sequences and may have different effects on transmission, antigenicity, and virulence. So these variants differ among their some of them are highly transmissible. Some are, the virulence is also different. Some of them cause severe disease, while others are not that pathogenic. So emerging, also the SARS-CoV-2 variants also differ in organotropism with interpatient variation in tissue sites evolved. So it also differs which the patients differ as to which organ is affected, which organ has been infected mainly. So emerging data also suggests that say patients infected with the SARS-CoV variant of concern have an increased risk. So some variants cause severe risk and impose, leading to the death, while others do not cause severe symptoms. So some of the, that's why there is a need for subclassification, which is necessary at least to understand the disease spread, its course and prognosis. However, their relationship to vaccine-induced immunity and host response, immunopathology, and response to COVID-19 therapies are also not very clear. Not all host responses are also the same. Once infected, the host has a dysregulated and variable response to COVID-2 infection. This variable response could represent differences in the conditions of the host. That means pre-existing general conditions of the host, maybe comorbidities or something like that, and also differences in the strain, differences in the infection. That means which variant he has been infected with which variant, and also the size of the inoculum, whether they are severely exposed or mild infection like that. So as well as also it is about the consequences of the differences in timing of various treatments. There are so many different treatments which are available, and the course of the treatment and also the differences in the timing of the treatments also has an impact. So although an initial description characterized the response to COVID-19 as so-called cytokine storm, it became evident that the magnitude of the innate immune response was variable and less than proposed. Consequently, for two patients with ongoing viral shedding, one may have a minimal disease while the other develops ongoing lung injury or thrombosis-related catastrophes. So this is a classic example of this differential individual responses to the same therapy. We has already been discussed previous speaker. So this slide shows the diversity of the drugs which are used for COVID-19 therapy and their associated adverse effects. Based on the currently published clinical trials, we try to highlight the efficiency and side effects of the drugs which are the top contenders for COVID-19 therapy. Self-medication is another problem. Self-medication, as described by WHO, it includes self-medication is where the patients use or reuse previously prescribed or unused drugs, or direct purchasing of prescribed drugs without consultation, and initial irrational use of over-the-counter drugs. As of September 1, 2020, about 30,905,162 confirmed cases of COVID were there, while no definitive treatment or vaccines were available to prevent the infection. This situation made people to go for self-medication due to misinformation from various social media sources. In developing countries such as India, use of self-medication with hydroxychloroquine has been documented, and the FDA also later declared that use of these drugs is not safe in mild to moderate cases on their therapeutic safety profile in COVID-19 patients. Similarly, in UK also dexamethasone was considered as life-saving drug for treating severe COVID-19 patients, and the UK Minister of Health himself declared the use of critically ill patients for its usage in critically ill patients. And ivermectin was sold over the counter in several countries, and some people self-medicated, more concerningly self-dosed it for the treatment of COVID-19. So this slide shows all the various herbal, the phytochemicals which have the therapeutic potential against COVID-12 from the research and from the available literature. And this slide shows the therapeutic potential of the herbal formulations against COVID-19. So, although all this literature are available, but we should be very very careful while using these treatments. Although this even the herbal medications, you can see the choice of medicines. Many people argue that the herbal drugs are widely used and they are safe, but the truth is they also are not devoid of any risks. Although these patented herbal drugs have been used clinically for several years, when we apply them on a novel disease like COVID-19, especially in combination with other drugs such as antivirals, antibiotics, and immune suppressants, safety should be cautiously evaluated. So many herbal drugs have been used to treat COVID-19 in China and India and other countries worldwide. Such products are readily available to the public without a prescription. So they are being used by many people, and they have been shown to reduce the hospital visits and admissions, but their usage in COVID-19 lacks evidence base. So we have to be cautious while using such medications which don't have any evidence. I mean, there are no clinical trials. So in China, 3 patented herbal products were recommended to treat COVID-19. However, their potential effectiveness and safety needs to be confirmed by the results of randomized controlled clinical trials. There are no clinical trials conducted. There were only some literature is available, which is based on the maybe animal trial or say in vitro or in vivo studies using animals or cell culture studies, or most of them are mainly bioinformatics studies. So similarly, there was increased demand and use for Sana Makki, a herbal plant, by local people in Pakistani due to claimed efficacy in treating COVID-19 symptoms. Like this, there are several countries, different countries, which have started using this herbal medicines. So many herbal drugs have been used to treat COVID-19 in China and other countries worldwide. So, however, due to limited knowledge of the dynamics of SARS-CoV-19 information and infection, SARS-CoV-2 infection, observed that the current COVID therapy has led to some clinical repercussions. So all the vaccination drives all over the world have now halted the infection breakthrough. Still the breakthrough infection is reported in fully vaccinated individuals. Secondly, even people who have been vaccinated have been found to be infected. Hence, in addition, there is unmet need for potential treatment for COVID-19. So despite this whatever vaccination trials which have been completed in all the countries, still we are finding newer variants. We have recently faced that Omicron virus. Luckily, it has not caused that much damage in our country. But still, in post-pandemic era, personalized healthcare solution is set to get prominence through technological advancements, leading to a paradigm shift in medical space to deliver an effective cure. We definitely need this personalized medicine is the only solution for this, because of the the different variants which are available, genetic variants. There pathogen is evolving pathogen which is generating more and more variants with differences in antigenicity, and also it is also causing various differences in its transmission, as well as in causing the disease. So there is a variability in with the pathogen, and also the variability among the individuals who are being infected. their ability to, their immunity differences, and obviously the differences in immunity and all this. So there is a need for this personalized medicine as a cure for this. So as there is heterogeneity in the host response to SARS-CoV, a more precise and tailored treatment is required for favorable outcomes. It is further anticipated and that identification of immune signatures in patients through wide genomic and proteomic analysis can be helpful in segregating the population, leading to more specific treatment and improved response to the therapy. The infected population that is segregated based on genotyping and critical immune signatures are subjected to different treatments such as anti-cytokine monoclonal antibody treatment, plasma, and also antivirals. The optimized treatment accordingly can be helpful in a much better response to current therapy. So there, interestingly, we have also seen some cases during the pandemic. We could associate some of the indications where some of the trials where by trial and error we have come up with some personalized approaches where the pulmonary inflammation index has been found to be associated with transmission of mild to severe COVID-19, whereas combining pulmonary inflammation index with cytokine profiling and immune signatures was found to be was linked with the severity of the COVID-19 disease and requires an optimized treatment accordingly. And also endothelial activation and stress index. This has been used as used for predicting endothelial dysfunction and based on the markers such as lactate dehydrogenase, creatinine, and also platelet counts. In a small study, we have in another study where the COVID-19 patients were distinguished based on different complications such as IL-6 mediated ARDS. IL-6 is a pro-inflammatory cytokine, so that was used as a marker for identifying the ARDS, and also acute respiratory distress syndrome, and also inflammatory response, co-infection, immune dysfunction due to C-reactive protein and hyperferritinemia. They have distinguished different complications. Based on that, they have IL-6 and IL-1 blockade were helpful in patients with ARDS. So when they found this IL-6 was high, it was associated with ARDS, they were, by blocking that IL-6 or IL-1 blockade, they could treat the ARDS patient. And patients with co-infection undergo appropriate microbial culture for antibiotic treatment. So they will also see the co-infection. If they are having co-infection, appropriate antibiotic treatment will be given. Like that, they could find some of the biomarkers which are associated with the disease severity. So this helped them. So personalized medicine is very important, whereby you can it will help us in identifying the genetic markers. So finally, actually, it helps us in identifying the genetic makeup. It based on the genetic makeup differences among the individual responses. That based on the genetic differences, we can come up with the differences in responses to the treatments. Overall, the study showed that personalized approach was beneficial in improving conditions in about 94% of the patients as compared with 60%. Nevertheless, the prior knowledge of immune signatures in the infected patients can provide a better prognosis and critical insights for determining the roadmap for personalized medicine. This picture very clearly shows the landscape for the personalized therapy in COVID-19, for COVID-19. Therapy. You can see the SARS-CoV infected virus. When they are on random therapy, people will be given just based on the severity or based on the severity and the symptoms. They'll be treated with either monoclonal antibodies or antivirals and things like that. This kind of random therapy will help in curing on less than 50% of the patients. Whereas when you use this personalized medicine, is based on the genetic differences. So we first have to subject it to genome, transcriptome, proteome, or metabolome. So by understanding this approach, by carrying out this kind of approach, genetic approach, identifying the it involves identifying the biomarkers based on these approaches, identifying the biomarkers, and then these drugs will be targeted to the allowed to interact with these targets through in silico approaches using artificial bioinformatic tools and also artificial intelligence. We can see the interactions which will be more effective. We will come to know, and then based on that we will be treating the individuals based on their needs. We will be treating with either monoclonal or antiviral or whatever. It has been shown to be effective in greater than 80% efficacy was shown. So personalized medicine is an emerging practice where therapy is based on inter-individual variation, that is based on the genetic makeup to guide the decisions with regard to prevention, diagnosis or treatment of the disease. Inter-individual differences, they determine the variation in diagnosis and also drug choice, dose level, ingredient selection and route of administration. So for personalized medicine is often focused on variations in genetic composition and drug metabolism among different individuals. However, inter-individual variation shall be also widened to pathophysiology, comorbidities and accessibility also. So COVID-19 pandemic exposes the possibilities and challenges in personalized medicine as there is a wide variation in the infection, heterogeneity in the provided treatment and the accessibility to medicine. So we have so much of variation with respect to the pathogen, where different variants, that means the infection also could be, there is a lot of variation in the infecting pathogen, and genetic differences exist among the individuals, and also the treatment also is variable. That's why here personalized medicine is the is a better option. Integrating personalized medicine into clinical practice transforms transforms the health, enabling the design of the preventive and therapeutic strategies tailored to suit the individual profiles, improving the detection of outbreaks or defining the transmission of the disease. So personalized medicine implementation in clinical practice requires multidisciplinary approach, putting together people working on genomic sequencing, bioinformatics. It involves people who are geneticists and microbiologists and physicians in charge of the patient, as well as the management of the big data. So it is not an individual thing. It is a multidisciplinary group is required for doing all this, for putting it into practice. It requires, it's a well-defined circuit. A well-defined circuit is mandatory together with multidisciplinary group, being able to frequently meet to solve complex situations such as severe COVID-19. So policymakers, healthcare leaders and physicians should improve our response to COVID-2 pandemic by promoting interdisciplinary collaboration and moving the main research and innovation milestones to clinical practice.
Oh.
Taking these points into consideration, one cannot rule out the importance of personalized therapy that could help dampen the COVID pandemic. And also heterogeneity in response to COVID-19 infection among individuals could be attributed to differences in genetic factors, age, sex, race, and ethnicity, which also necessitate variable therapy. So additionally, the emergence of new SARS-CoV variants may compromise the current vaccine drive. Hence, now is the time to shift our healthcare system to more focused approach. So personalized medicine plays a key role in elucidating individual susceptibility to infection as well as inter-individual variability in clinical course, prognosis, and treatment to response to treatment. Due to the advancement in the biomedical field, now it is not possible to incorporate this precision medicine in our medical practice, but it may be this can be overcome by involving use of more sophisticated diagnosis, superior which work with superior sensitivity, and also using artificial intelligence, we'll be able to predict the optimum drug and doses required for a patient for better outcome, effective outcome. We can see here the importance of telemedicine. So telemedicine and digital health technologies are also go hand in hand. with personalized medicine. As we have also already mentioned, that genomic sequences followed by bioinformatic target identification and the in silico approach, where we can see the interaction of the drug targets with the interaction with the drugs, and that's how we can choose the appropriate treatment. So everything has become digitalized, and the only thing which needs utmost government is the healthcare sector. So now that the pandemic exposes the modern needs, the pandemic highlighted the need for accessibility of the care in the right time, telemedicine initiatives, and strengthening the primary care essentials for the diagnosis, essential for the diagnosis and follow-ups. The pandemic also has highlighted the need for more accessible support. And
Dr. Hariprasad, we also have another speaker.
Yeah, I know, I'm aware. I think I'll request Dr. Vijaya to conclude.
This is the last slide, sir.
Yeah.
So the pandemic has driven, innovations in vaccines, treatments, and access to care, has also given us a chance to deliver care in a coordinated ways, realizing the roles of pharmacists, physician assistants, nurses, and other providers who have played role during difficult time. The systemic framework to link all the healthcare providers is also imminent. We can see a good healthcare sector is one of those pillars which form the foundations of good healthcare. This is how you can see how the government initiative also helps. The transformation requires government policies, strong medical infrastructure, medical tourism, increased use of technology, and awareness of healthcare, health insurance.
Thank you, Dr. Vijaya, for the informative talk and for bringing out new aspects of COVID and how data and artificial intelligence can help. And you spoke a lot about herbal medicine, and Ayush was one part of your slides. We're very fortunate to have Professor Tanuja Nisari, who is the Chief Executive Officer of National Medicinal Plants Board of the Ministry of Ayush. I'd request her to address us, and this will give a greater insight into what we could do in terms of transforming healthcare using traditional medicine, that is the Indian medicine. Over to you, Dr. Tanuja.
Okay, thank you very much, the Chair, Hariprasad ji, Punit ji, and all esteemed panelists. May I share the slides? I have prepared the presentation.
Please do.
Thank you. I do not have the access to share the slides.
No, you can do it at the bottom of the screen. Just share screen.
Yes, yes. Yeah. Yes. Is it visible now?
Yes, you can go into the slideshow mode now.
Yes. Is it visible now?
Yeah, very much, and you're audible. Please go ahead, doctor.
Yes, thank you. I'll not take much time, but since this is I may not be an odd man out, but it is the most complementary medicine, what we can say during COVID-19. We could see it's the focus, the discussion is personalized, preventive, precision, and emergency medicine. So in all these 3P, especially in this COVID time, in the prevention and also precision, we could really see the potential of this system of medicine, that is Ayush, Ayurveda, Unani, Siddha, and homeopathy. And I'm just more speaking on the Ayurveda because maybe our international speakers and the audience, the Ayurveda is an indigenous system of India, and it is deeply rooted in our community and in public health. And it has the potential to meet health and wellness for all. And we could really realize with its own strength, which is really imbibed in our own culture, we could really take care of many COVID-19 mild to moderate, just prevent them to reach to the next level. That's what is our experience. I would be happy to share with that. And in view of the latest last week we celebrated World Health Day, and it said that our planet, our health. And Ayurveda, like India, it is a Vasudha Viva Kutumbakam. And true is for the Ayurveda, because Ayurveda says that Yat Pindet Brahmande. That means you are a universe within the universe. You are a part of the nature and use nature's own properties to balance yourself. Exactly the same principle we use to prevent, to balance and create harmony with the external environment within ourselves. And that was the key, and that is the key as a prevention, personalized prevention and precision medicine. Now to clarify more, the journey as it is says that the science of life, knowledge system of healthy and happy life, the journey starts from illness to wellness in many of the systems, but Ayurveda says that it is a science of healthy and happy life, hita hitam sukham dukkham. So it really includes as an addition as a happiness. And in the COVID-19, we saw that many of them, they had more stress induced depressions, anxiety, and many others, and we could really provide them care with compassion, and that really was not wellness but happiness as well. And as you see that Ayurveda is a most precision, individualized, personalized medicine, because whenever we select any diet, recipes, lifestyle, or medicine which is holistic in nature, that is according to design and customized according to body prototypes, that is a constitution as a vata, pitta, and kapha. And accordingly, the one which has a hot temperament like pitta, the medicines of a cooling nature, and the diet lifestyle. So the same is true for each and everything, for maintenance of the health as well as prevention of disease, promotion as well as treatment. And the management is customized, selected, and tailored as per the temperament. If at all we don't do like that, even though whatever the antivirals and the remdesivir and many others, if we don't consider the individualized person, so it was observed, what we have studied, that the medicines really had not effect, and they really we could see in more pitta persons, more complications were observed in COVID Health Center at All India Institute. So this is the most personalized preventive medicine, and that's how we can integrate this knowledge into the mainstream medicine as what we say, and that is how we say that it is the best of the best system integrating together for the better outcome, which is patient-centric integration. It says that it is a maintenance of positive health is the first principle, main objective of this knowledge system, and then it is a treatment. So we say that it is the greatest gift to the humanity, monumental contribution to the entire world. And since beginning, it has been divided into 8 branches like Kaya, Bala, so internal, pediatric, geriatric, ENT, ophthalmology, everything is Ayurveda is evolved for many thousands of years. Why I am telling this today? Because if you can look at the 8th branch, that is a rejuvenation, immunomodulation, that more focuses on building up the immune system to individual, and all the knowledge regarding diet, lifestyle, supplementary, and the diet supplementation and the thought process, everything has been reiterated and clearly mentioned in this 8th branch. And for all autoimmune disorders and COVID-like conditions where immune system is more compromised, even though it is a hyper stimulation of our immune system, maybe it is a cytokine storm, but whatever for down regulating, also boosting or modulation, this branch we have really utilized this strength during this COVID mitigation of COVID-19. And each and everything starting from common cold to cancer, the cause, effect, and the management is the principle for each and everything in all 8 branches. And it is management is holistic, not a single herb, single medicine. What we observe that it is not the one pill which we could offer to holistic treatment and complete cure. And we could understand that my health is my responsibility. So when means it is 100% individual specific. So the one who really could take care of their diet, lifestyle, and all other aspects of the immunity, they could really prevent themselves from getting infected or progressing to the severity. And that's how we do holistic management with biopurification, panchakarma, oral medication, diet, lifestyle, yoga, and meditation. And that's why the journey really comes from illness, wellness to happiness. Yes. And that's how the maintenance of health really tells us about prevention, promotion of that, and that's the strength of Ayurveda. And then comes swasthasya swasthya rakshanam aturasya vikara parimoksham. And that's how this management also is a holistic, as we mentioned. But how do we really take care of personalized medicine and the maintenance of the health? It's a diet, sleep, and daily routine celibacy. And that's how the aim, how do we really meet this objective, especially in this pandemic condition. It is prevention, promotion, treatment, palliation, and it is all at individual, family, community, and the national level, and also at the global level. And that's for this a Ministry of Ayush. It's a separate ministry has been created. There is a well systematized medicine and medical system, we can say, because you can see that more than 700,000, 7 lakh registered practitioners. Unlike to any other medicine, India is really blessed to have a robust system mechanism where it takes care of research, education, drug and cosmetic, where standardization, as really would like to tell to the previous speaker, madam, that we really have one in pharmacovigilance program where it takes care of adverse drug reaction and also drug to drug interaction, and that we could really observe and we could really promote during COVID pandemic through various advisories and through 8,000 and more than 9,000 manufacturing units where GMP certified manufacturing medicines are being created. And we really would like to promote that OTC product is not only the Ayurveda. Ayurveda is a prescription medicine where more than 8,700 medicinal plants are being regulated by the Act, by Drug and Cosmetic Act. And if that, what is the more need is to create awareness among the society that which is the authentic and which is substandard. So that is the big challenge with the Ayurveda. But what we have observed at All India Institute of Ayurveda, that through these 8,700 medicinal plants, which includes 1,500 Ayurveda, Siddha, Unani, we could really utilize, we could save the lives of many, and also post-COVID complications. And during COVID also, this not only the symptom management, but also boosting their immunity and modulating their immune status and quality of life. Because India is blessed to have 2 biodiversity hotspots, and in various part of the country, the various plants are more prevalent. What is more strength of this system is not only the physician, but the patients are Savaso Crore Deshwasi, that is our population, citizens of India, because it is imbibed in our culture. They are all aware about the strength of Ayurvedic medicines. And our study with Sanjeevani, app Sanjeevani, that could showcase that more than 87% of the respondents mentioned that they were using some or the other supplementary medicine along with the COVID, because there was no sure shot, and there is still no sure shot medicine as an anti-COVID. But with this strength, we could really save the lives of many. Medicines, quality, safety, efficacy, we have drug and standardization. I am also CEO of National Medicinal Plant Board and also director of All India Institute. So we could see that the very various use of standardized medicine where we had developed the standard treatment protocol, and also very important because this COVID-19 is also novel coronavirus. So the nursing and paramedical staff also need to be trained. What is neti, what is dhupana, and some procedures, therapies which are augmenting, which augment the outcome measure at individualized level. And that was the strength. It is acceptance, emphasis, individualized approach is the one which is very, very important to this medicine, this system, and that we really could use. Stress on public, natural product, multiple areas, and that's how it is preventive, promotive, predictive in its true nature. If we use it with adhering to quality, safety, and efficacy, then it really becomes the boon to the society and the mankind. how do we really ensure that this prevention and personalized medicine is really effective and it becomes in truly my health, my responsibility, because it is not only PP medicine, but more important at this forum, I would like to say it is a participatory medicine, because participation from the individual is very, very important to prevent many diseases. The pill cannot prevent disease, pill cannot treat if there is no participation from the individual. So what we reiterate, if we divide 8 3s are 24, so diet and 8 hours sleep is very, very important for individualized health and prevention of the diseases. Then the exercise, massage, and then 8 hours professional life, work-life balance, and 4 hours morning and 4 hours evening is which we very important is the massage, exercise, yoga, and seasonal panchakarma and rejuvenating herbs. And all those module is the one which is very important for prevention. And as a personalized medicine, this module very is different in Vata person, Pitta person, and Kapha person. For the obese, more exercise, robust exercise is important. Lean, thin, and very sensible to the heat. We really advocate them more yoga. One which is very anxious, we advocate them cooling and meditation and Kapalabhati to the more kapha person, and different type of pranayam to a different person. So it is not only one, it is not that 3 protocols had been mentioned. Even though this is the dinacharya, that is daily regimen, we advocate for everyone, but there is a variation who should take the water from the copper vessel, but not all, not pitta person, but kapha person. Then if we adhere to all these, because during COVID time, what we recommended, that is a gargling, very, very important. Nasal administration, the most important, because the study suggests that those who really did the nasal administration with the lipids, it is medicated oil, anu tel, or different types of oil, there was 90% reduction of viral load. And All India Institute and NMPB have conducted study with the TISTI, that is CSIR lab, to understand the molecular mechanism on hamster model. And to our surprise, there was a 90% reduction, so that protein spike of the virus could not bind to the nasal epithelium and the SAR receptors in the nasal epithelium. And also the Gandusha Kavalagraha, that is a gargling, also really helped preventing the entry of the virus into the through the oral route. But what is to be, whether it is to be medicated water or the oil, that depends on the individualized temperament, and that really we could advocate during this COVID-19. And it is also the seasonal regimen in summer, in winter, and in the rainy season. The same daily regime needs to be tweaked and modified to adjust to bring the harmony with the circadian rhythm and biological clock to the universal clock. And that is the main important aspects of bringing creating the balance and the health. And as we say that the diet really plays important role in bringing boosting the immunity and also preventing the disease. And it is not the wholesome as a protein, carb, and fat and the nutritive value, but Ayurveda says that 6 days, 4 forms is the balanced diet. Like Indian diet, it is the rice, bread, vegetable, curry, all together. All rainbow diet is the one which is the balanced diet. When to eat, what to eat, how much to eat is also very important. And that's why between the sunrise to sunset, if someone eats its breakfast, lunch, and dinner and remains fasting during the night time, I think that's the way of bringing boosting the immunity and also preventing the disease. And the study also says that immunity depends on the type of the diet. It is not only at the physical level, at the mental level, thought process, intellect, memory, and the stress. Everything depends on the type of the diet, as Ayurveda says that Sattvic, Rajasic, and Tamasic is the way. And second, the sleep, very important, as it says that the It is not getting enough sleep is linked to many chronic disease conditions like type 2 diabetes, heart, obesity, and depression. And in COVID-19 also, those with comorbid conditions and those who could not sleep, really their conditions got aggravated. That we have the record of many such patients at COVID Health Center, where all these conditions are really alter the disease outcome and the outcome measure also. And that was overlooked, but we really have studied, and it says that LC is one such area in the brain which is severely affected by sleep deprivation, and it really is the principal area in the brain. Hence, it is important for cognitive functions, memory, stress response, and emotional reactions. We have seen a few patients who could not sleep during COVID because of anxiety, depression, but post-COVID psychosis was more predominant in the patients who could not sleep during their active time COVID conditions. And hence, these are very important areas, and we see that the different dosha predictors and its sleep outcome there is a correlation, and that's main crux of personalized medicine. Now coming to Ayurveda and yoga, because yoga is the physical, spiritual face of Ayurveda, and Ayurveda is the physical face of Ayurveda. So we have developed the combined protocol Ayur Yoga, two sides of a single coin, as our Honorable Prime Minister also has promoted International Yoga Day in more than 190 countries, and also 5 minutes yoga break. If someone is not able to follow yoga protocol, during your office time, during your busy schedule, if 5 minutes break is to be observed, that really induces the mental stability, gives relaxation, and that really helps you in bringing down your stress level. And that's what we observed in our COVID Health Center at CHC at All India Institute, where yoga, meditation, recreation, and rejuvenating herbs were also added in our COVID protocol, where Aula, Amalki, Indian gooseberry, Tinospora cordifolia as a guduchi, Ashwagandha, Pithania somnifera, turmeric, then draksha, resin, and shatavari. These are some of the herbs, very important herbs, which have immunomodulatory, antioxidant, anti-inflammatory activity screens. These were very, very important in really helping. If we really give them first day, so the first 7 days are very important in the COVID, so that from 7th day onwards, cytokine storm did not really happen, and that modulation was very important, and bringing down C-reactive protein, CRP level down, pro-inflammatory cytokines down. So this ashwagandha really helped, and we have various robust studies where it is even not only in COVID, but even cancer also. And it says that it's chemo prevention, and it reduces cell viability, induces increase of apoptosis, immunization. So there are many studies which are done on these herbs, and that really helped us, says that it is really effective. I just end by giving one example of this preventive kit which we gave to 80,000 Delhi police personnel, and that was only for the prevention during the first wave, and it included Tinospora cordicolia tablets, Anu tel for nasal administration, Chavanprash, and the decoction herbal tea with the spices, Ayush Kadha. And what was the outcome? Very interestingly, when other metro cities had the COVID wave up, Delhi personnel really had the prevention, and also when Delhi population had the COVID wave up, there was a COVID wave. The trend was going down, and the mortality rate you can see is less as compared to Delhi population. It was 1.23, and here it is a 0.2. And we have studied also control study where COVID antibodies are found more, 53% in the control group, and where the preventive kit was given, there is only 17%. So this really suggests that the preventive kit really helped. and it was all personalized approach. We had done, this is the kadha question, which include dalchini, kali mirch, chunt, tulsi, and decoction, which we were prepared through our government manufacturing unit, adhering to all the standards, and that really gave us prevention. Now coming to personalized personnel which were posted at CHC, you can see in other metro hospitals, the death rate was more and even the infection was more, but those who were posted at COVID Health Center, they were also following the same protocol, and you can see the incidence is really zero. And in COVID Health Center, the national average recovery time was reduced to 50% with less mortality. This is some of the immune boosting measures and self-care measures that really helped many. I know that OTC is not really good, but with diet, lifestyle, and advocacy of this, even the prevention could achieve. And it is always blamed that this practice-based evidence is used in this Ayurveda, but I can assure now that it is a evidence-based practice which is being translated into community. And during COVID-19 also 139 clinical research projects have been registered in CTRI, and you can see there will see now that the time is changing and more evidence is being created to integrate, to complement the strength of this system into conventional medicine, so that the future of the medicine becomes no medicine either or the integration. And that's how now we are really proud to announce and say that our Honorable Prime Minister and the DG WHO will be launching the Global Traditional Health Center in Jamnagar in India, and we take this pride that GCTM is being launched. That really is meant to integrate the strength of all traditional systems across the globe for the mainstream medicine, so that the integration is patient-centric and we get the better outcome. Thank you for this wonderful opportunity.
Thank you, madam. And we hope that there'll be a day when Ayush becomes the mainstream of healthcare, and that would be a true transformation. I would like to take this time to thank all the panelists for their views and the work that they've done during the most difficult times, and also sparing this time, although we delayed quite a bit, but I guess there has been a lot of learning for those who participated. And I would like to conclude by thanking the organizers for giving us time to share our views and also understand and learn from each other. Thank you very much.
Thank you, Dr. Hari Prasad and distinguished panelists. One thing I have learned, that we should have a separate session next year for Ayurveda medicine. And this is a wealth of information. Everybody should share this knowledge. And with Dr. Tanuja, we will cooperate and see that one session will be supported and sponsored by Ayush Ministry.
Thank you. Thank you.
And Dr. Tanuja, it will be there on 12th and 13th of April next year.
Sure,
okay?
that I will be on that. Thank you.
Yeah, it's a wonderful information, and all the panelists has done excellent job, chaired by Dr. Hari Prasad very ably. Thank you very much. Thank you for all.
Thank you and bye-bye.
Bye-bye.
Thank you so much, Dr. Hari Prasad. Thank you so much to all the gentlemen, Dr. Sergi and Dr. Meena and Dr. Dk Gupta and Dr. Vijay, as well as Dr. Tanuja as well. Thank you so much, gentlemen, for a very invigorating session. And now let me announce the next plenary session that is going to be on recent advances in oncology detection and treatment. And I'm very pleased to announce that we have a very distinguished panel that is going to participate in this session. The chair for this session is going to be Professor Giuseppe Curigliano. He is the Clinical Director, Division of Early Drug Development for Innovative Therapy and co-chair Cancer Experimental Therapeutics Program, Department of Oncology and Hemato-Oncology, University of Milan, European Institute of Oncology, Italy. Very good evening, Professor. Very warm welcome. And the key speakers for this session is going to be Dr. Geeta Manjunath, CEO and co-founder, Niramai Health Analytics. Very warm welcome, ma'am.
Thank you.
Dr. Om Sharma, Executive Director, Clinical Development Oncology, Hengrui Pharmaceuticals, USA, is also joined us. Dr. Om Sharma, very warm welcome to you as well. And we have Dr. Alain Chappell, Department of Man Radio Protection, Institute of Radiological Protection and Nuclear Safety, France. Very warm welcome, Dr. Chappell. And we have Dr. Homan Soli Mani Majid, Consultant Gynecological, Churchill Cancer Center, Oxford University Hospital, UK. Warm welcome to you, sir. And we also have Padma Shri Dr. Harsh Mahajan, Founder and Chief Radiologist, Mahajan Imaging Chairman, Caring. So a very warm welcome.
Thank you. Thank you.
All of you gentlemen and ladies for having joined us in this session. And if we have the chair who has joined us, I request Professor Giuseppe. Do we have Professor Giuseppe who has joined us? All right, it seems that we don't have Professor Giuseppe at the moment. So I request this first speaker for this session, Dr. Geeta Manjunath, CEO and co-founder, Niramai Health Analytics, to please start the session that is going to focus on recent advances in oncology detection and treatment. Over to you, Dr. Geeta.
Sure. Can I share my screen? Yeah, I can.
Yes, ma'am.
Warm good evening, everyone. It's a real pleasure to be on this panel of eminent panelists, my favorite Dr. Harsh Mahajan sir as well. Of course, there are several advances in the treatment of oncology, that is cancer, in trying to sort of make it less painful and try to save lives once cancer has been diagnosed. So as a computer scientist, as an AI scientist, with PhD in machine learning and 25 years of experience with Hewlett-Packard and Xerox research, as a technologist, what we wanted to do is to try and use AI, artificial intelligence and machine learning, to save lives, to enable early detection. And of course, I don't want to give an introduction to AI, but if you look at AI in healthcare, and particularly for clinical decision support, one of the best areas where it can make huge impact is in medical imaging. How patterns in videos and images can be detected automatically by machines and at least marked, the abnormal areas marked so that the clinicians can take a better decision. So in this regard, I'm the founder and CEO of Niramai, where we are looking at non-invasive risk assessment with machine artificial intelligence, that is using AI to non-invasively detect health risks. And one such effort that I want to bring today in the next 10 to 12 minutes is Thermalytics, which is a new test for detecting breast cancer that we've been able to come up with. And this test called Thermalytics is an affordable, accessible, and accurate breast cancer screening test. And I'm going to take you through this. Just a bit of the context, most of you are aware possibly that breast cancer is one of the largest cancer killers in women today. 684,000 women died last year because of this disease. And in fact, this is one of the most curable of all the cancers, but still we're losing 684,000 women every year. And out of this, more than 90,000 women are dying from right out of India, because though the number of cases are not 15% of all the world's cases, the number of deaths is. The survival rate in India is just little over 50%. every alternate lady detected with breast cancer is dying, because early detection is very, very critical to save lives. And 96% of the people actually are detecting after a symptom is formed. This is a problem that we wanted to solve. Then we asked this question, why is early detection a problem today? Why aren't we able to do this? And there are several reasons. One, of course, is the awareness about breast cancer, that in India, it is 1 in 26 women who can get breast cancer. Apart from that, the affordability and accessibility of the current methods have, several papers have shown that it is not scalable to do a population level screening, every month screening every year, or maybe a certain age group screening every year. This is not a feasible implementation from the government or any other infrastructure if you're using the standard modality, which is the mammography, because the machine itself is expensive. You need, a very good radiologist to interpret it, as well as technicians who are trained well to actually do the imaging. In addition, mammography has low sensitivity in women with dense breasts. Basically, these are most women under 45 years of age, and almost 50% of women above 45 years. Because mammograph is just an X-ray of the breast, which is great, because it has been proven to actually save lives when used as regular screening modality in general. However, women with dense breasts will have an image like the second one, where the whole breast appears white and you're trying to find a white spot in it, because of which it's very difficult, and hence sensitivity drops really almost close to 50 to 60%. And that is one of the reasons why mammography is not recommended. So there is no good test for women under 45 years of age. And in India, the number of dense breast women and the age for breast cancer is almost 10 years younger than the rest of the world. We can talk a lot about this, but let me go into what we have done to address this. So these are some of the issues, and Niramai has developed a new method, as I mentioned, called thermalytics. We use thermal imaging and artificial intelligence to detect these small cancers or even bigger cancers. We are able to detect much before a lump is felt. Some of our studies show that we are able to detect 4 millimeters of cancers and 5 millimeter, right? 4 millimeter benign and 5 millimeter malignant is the smallest so far we've detected. Both were non-palpable before actually having a symptom. That is stage 0, stage 1. Another important factor to have conformance that every lady needs to do, and she feels good to do the test, is about just making it more comfortable. So the test that has been developed is non-contact, non-invasive. The lady sits in front of the device just like this for 10 minutes. Nobody sees her. It's like a changing room. She goes in, closes the door, and the technician also is outside. No touch, no see. Absolutely no radiation, because we just measure the temperature that's actually on the skin. And of course, there's no compression and there's no pain as well. We have tested this solution on multiple age groups of women, and it does work on women under 45, also above 45. In fact, we were unfortunate to detect a 17-year-old with cancer with this, and of course, confirmed with biopsy later. Potentially, it can work on men too, though only 100 men have actually taken the test, because there is no flesh to be put between the two plates. It's much more affordable. The capex itself is 1/20th the cost of a mammogram, and a simple technician can be trained to do this initial screening and report generation. It's a very portable device, just the size of a water bottle, and you could actually put it in a backpack and not just do the test in a hospital, but it can also go out and you can do the test in community screening, corporate screening, offices. And also we started private screening at home during COVID time, and it was very helpful to many women in India for now. So the magic here is because of machine learning on thermal imaging. So this technique, as I mentioned, is a combination of advanced thermal imaging and machine intelligence. It doesn't matter how you measure the temperature. There are different devices, wearable devices, contact devices, non-contact devices. We use an infrared camera to measure them. Just measuring temperature is not enough to detect breast cancer. The analysis of this is very critical to actually get the levels of accuracy that is needed for real clinical use. So if you use an infrared thermal imaging, you actually get an image like this, where every point here represents a temperature value. So what you're seeing here is about 4 lakh temperature points per person. A white is the highest temperature and blue or black is the lowest temperature. It's basically a heat map. Now, we have developed these machine learning algorithms trained over multiple thousands of images to actually identify if there is an abnormality, what is the probability that this abnormality is actually malignant, possibly, and also mark the area of likely location of the lesion so that a follow-up ultrasound can be a targeted ultrasound trying to figure out if it's really malignant and then do a biopsy, which is ultrasound guided. The software is the main innovation. There are several thermal imaging devices which are still not in real use. By making this smart AI-based software to analyze these temperature points and generating this interpretable quantitative report, non-subjective, that is a same value is given irrespective of who does it, right? And so that kind of an objective assessment is what is making this affordable and accessible and possibly non-subjective and accurate. It is very unique, made in India and developed here, and it has resulted in 26 granted patents around the world in the US, Singapore, Japan, China, India, of course, and other countries. All 10 of them are right in the US and 25 more pending grant right now. The AI software is also CE marked, and recently we also obtained an US FDA clearance for the same. A small video showing the experience, this is a thermal imaging device. She's sitting in front of the device and she's just turning on the stool to get a 360 or 180 degrees view, the lateral and the oblique views. And that's about it. The report is generated. It is actually live. 52,000 or more women have actually gone through this test. It's installed in 100 plus locations, clinically tested in very reputed hospitals, including HCG, Narayana Hrudayalaya, and several other places. And in the interest of time, I'm just sort of rushing, but there's a bunch of machine learning algorithms in this whole piece, including to make sure that the image is good quality and guide the technician to take the right kind of images. And then the segmentation, as well as a report generation in a way that it is semantically interpretable reports, right? And I'm happy to take you through more, if there is time, but basically the quantitative scores that we generate indicate the kind of level of abnormality or the health status, and any of these scores being greater than 0.5 is an indication of an abnormality. And also the images which are automatically generated, like I mentioned, also mention essentially the likely location of the lesion itself. And in villages, when you take this out, it just gives a triage report completely automatically. A red, yellow, green, and a person with red basically needs to come to a hospital for a further follow-up or diagnostic workup, and then of course biopsy. Yes, the clinical performance has been tested in multiple clinical studies. And this is one which was published in ASCO JCO, Journal of Clinical Oncology, where we did get a highest level of sensitivity for asymptomatic women and also reasonable high specificity as well. And when you compare the same on the same cohort with mammogram, and there's a considerable difference in the sensitivity, which is the reason being the dense tissue or heterogeneous of dense tissue. And just to give you an indication of that, you can see these are two mammograms of a heterogeneous dense and dense women. And this is how the thermalytics output, the contrast enabled annotated thermal image. You can see that in the second one, there's cancer. The first one, there isn't, and it's not obvious in the mammogram. However, in the thermal images that is generated, yes, it's very, very obvious, big blob, which is automatically marked, and it was further confirmed with a MRI guided biopsy. And several such studies have been done to show that this is an efficacious test. And that's the reason why we got the European as well as the US clearance. These are some of the patents. And it's very important for a healthcare company developing new things to actually be completely conformant with regulatory requirements, which incidentally also has clinical efficacy as one of the parts. And because of this reason, this particular test has won the Best to Diagnostic, that is the National Startup Award last year in diagnostic category, and several other awards. And also this makes India in the top 100 AI startups in the world. As you can see, Niramai makes India blue in this, the top 100 startups world map. Thanks a lot. I'll be very happy to answer any questions on this at the end of the, thanks a lot for your patient hearing. Or do you want to take the questions now, the moderator?
Ma'am, you done with the presentation?
Yes.
So, ma'am, we can have the question hour session after the end of everybody's, once everybody's through with their presentation, then we can have a question hour session.
Sure, no worries. I'll wait. Thank you.
You can, or if you want, we can have a question answer session right now also.
Either way, please go as per your plan.
All right. So thank you so much for that wonderful presentation. And I guess we don't have two speakers here. So I think we shall go on with the next set of speaker. So I will request Dr. Om Sharma, Executive Director, Clinical Development Oncology, Hengrui Pharmaceuticals, USA, to please go ahead with the presentation. Over to you, Dr. Sharma.
Yeah, sure. I'll be fine. Thank you. Let me share my slides. So my slides are visible now, right? Just want to make sure.
Yes, if you could make them full screen, it'd be great.
Yeah, I'm going to put in the. Is this good?
Yes.
Okay. Perfect. So thank you very much, Dr. Aishwarya Kapoor, for introducing. And I would like to start with thanking Dr. Anil Garg for giving me an opportunity to come and speak with the group today. I'm going to talk about the sort of precision medicine in the prostate cancer. So emerging role of PARP inhibitors, which are poly-ADP ribose polymerase inhibitors, as a precision treatment option for patients with prostate cancer. Okay. Sorry, I'm just trying to adjust my screen. Okay, so I'll divide my talk in few points to cover. So I'll give a very brief background on the prostate cancer and its prevalence and the current status of treatments, what are available as of now, and then to going to the PARP and homologous recombination repair pathways. What are they? Very briefly, I'll go there, and how those pathways could be exploited to develop the precision medicine in the prostate cancer using the current mechanism of action is synthetic lethality, means to taking advantage of PARP as well as homologous recombination pathways, and how we can use that to develop therapies. And just will give you a couple of examples of PARP inhibitors which are currently available in the market or were approved by FDA, at least in the US, and will summarize with opportunities and challenges. So regarding prostate cancer, as we know that androgen receptor is a ligand individual transcription factor, and that is mainly responsible for the prostate cancer because it initiates and for the growth as well as progression of prostate cancer. Androgen receptors are responsible, and therefore androgen receptor inhibition through ADT, androgen deprivation therapies, is the primary target for androgen signaling axis, and that has been the first line treatment for all types of prostate cancer, actually. So from like early on to advanced prostate cancer. But despite all those androgen deprivation, progression to castration-resistant prostate cancer has been a major problem, and that is still a lethal form of cancer. Androgen receptor is known to participate in tumor progression through three mechanisms. One is the activation and upregulation of the receptor pathway. Next is point mutations in the receptor itself, and ligand-independent activation. So even if the androgen receptor is totally inhibited, but there are independent pathways which are responsible for the prostate cancer. Briefly giving about the prevalence, prostate cancer is the second most diagnosed cancer type in men and sixth largest one for the death in men actually. And about 27% of new cases, and out of that about 21% deaths are estimated in the US in this year alone. And we know that incidences have remained stable in the local disease stage, but increased by about 4% per year for the localized cancer and about 6% per year for the metastatic cancer in the last decade or so. Therefore, prostate cancer diagnosed at the metastatic stage has increased from 3.9% to 8.2% over the last decade or so. And in general, the prevalence rate is about 12.5% lifetime prevalence rate. And obviously it is higher in the 70 and older group, about 9% versus 5.1% in the age group of 60 to 69. This to show just a trend in different cancers have been shown on this slide, but prostate cancer in the early 90s spiked, and then it started going down until about 2014, and then it started going up. And these data are based are taken until 2018. And if we take the stage of prostate cancer and in different population, so it's in population-wise, there is not much difference between black or white population in the US, but if it is detected in localized and regional stage, then the 5-year survival rate is pretty good. But look at the distant, when it is detected when it already is metastasized, then the 5-year survival rate is pretty dismal. 30 to 31%. So what we have as of now for the prostate cancer is a lot of development has been done in the early detection and treatment of localized prostate cancer. But again, as I mentioned earlier, the metastatic prostate cancer is one of the most common cause of male cancer death. And the standard of care as of now for prostate cancer is the androgen deprivation therapy and first generation androgen receptor axis targeting agents, for example, flutamide, bicalutamide, and nilutamide. Next generation androgen receptor inhibitors, abiraterone, enzalutamide, apalutamide, and darolutamide, taxane-based chemotherapy, radiopharmaceuticals, and immunotherapy. All of these drugs have improved outcome in the past decade, but metastatic prostate cancer remains invariably fatal because there is no real cure as of now. So new therapeutic strategies involving molecular stratification for personalized treatments means for the specific types of cancer type in a particular patient, that option is still very important and needs some research. And in that direction, I'm going to talk about the two systems, PARP and homologous recombination pathways in the prostate and how they could be exploited to develop the treatment. So just to talk a bit about the mechanism that the poly-ADP-ribose, it's a post-translational modification and signaling molecule that regulates many aspects of human cell biology. And it is synthesized by the PARP enzymes. And one of the earliest events in the DNA damage is DNA damage repair is the part 1. It rushes to the damage site, and what it does is resulting into activation and synthesis of these part chains on histones, non-histones proteins, and on itself, and that's how it prevents the DNA damage. How this could be exploited, this the pathway is one of the mechanism we call synthetic lethality. And I'm going to talk about that is that DNA damage is repaired by a slightly different mechanism. So for example, if there is a single strand break, it is repaired by the base excision repair mechanism, and homologous recombination, the double strand breaks are repaired by homologous recombination or non-homologous end joining mechanism. And there are bulky adducts, they are repaired by nucleotide excision repair. And in the replication errors, they are repaired by the mismatch repair mechanism. So approximately actionable mutations in DNA repair genes are about 20 to 25% cases, and germline or somatic alteration in BRCA2 are most common, approximately 12%. And homologous recombination defect render these tumors sensitive to PARP inhibition. So I'm going to talk on the next slide that how PARP inhibition can help in the homologous recombination repair defect patients to develop these drugs. So DNA damage repair defects can induce tumor-specific vulnerabilities that can be exploited to treat many forms of cancer, using these drugs which interfere with the DNA damage repair mechanism, causing cancer cells to stop replicating and die. So BRCA1 or 2 dysfunction sensitizes cells to inhibition of PARP enzyme activity, resulting in chromosomal instability. And cell cycle, of course, chromosomal instability is going to induce cell cycle arrest and subsequent apoptosis, and that is how we exploit this. So genomic of localized and metastatic castration-resistant prostate cancer can be utilized to guide more precise cancer therapies, such as incorporation of PARP inhibitors in the metastatic castration-resistant prostate cancer towards the path of precision medicine. And this is just to show that BRCA1, so BRCA2 is the major, this thing about 42%. And if you add BRCA1 to that, it becomes 51% of the mutations are BRCA1, BRCA2. These are mutations in homologous recombination repair mechanism. And the rest of the other genes, ATM, CHEK2, and rest of them, they make the overall 16 DNA, which could be exploited to be targeted. So PAR proteins, let me just give me a few seconds. Yeah. So PAR proteins are DNA damage sensor. As I mentioned earlier, they are signal transducer. So as soon as they bind to single strand breaks and synthesize poly-ADP-ribose chains on target proteins, also called PRylation in the vicinity of DNA breaks and itself. So that's how they rush to the DNA damage site and repair that. In normal cells, these breaks are repaired by homologous recombination repair. However, if homologous recombination repair is deficient, it's not there, then these single strand breaks will convert into double strand break. And then they will fail to repair these breaks and they will result into cell death. So BRCA1 and 2 are most common and well-characterized genes involved in homologous recombination. ATM function as DNA damage checkpoint and indirectly activates homologous recombination repair. And loss of function mutations in these and other genes with direct or indirect role in homologous recombination are associated with more aggressive prostate cancer. And so this is, keep in mind that this is both responsible for the aggressive prostate cancer. At the same time, we can exploit these pathways to develop drugs. So such gene alterations, they confer sensitivity to PARP inhibition in prostate cancer, and the response to PARP inhibition may occur through two but distinct pathways. These are, one is catalytic pathway, another is PARP trapping. I'll talk about those on the next slide. So this is a kind of the cartoon showing you the synthetic lethality, how it works, PARP inhibitors and HRR deficient cells. So any of the either PARP pathway or homologous recombination pathway, either one by itself is not lethal. But when both of them are there in a cell, then they become lethal. So if, for example, if PARP1 and homologous recombination, HHR, are active, then if there is a DNA damage, it will be repaired. If there is a HRR deficient, but PARP is still functioning, still the cell will be repairing the damaged DNA. So in cases of, if you are using cancer drugs to inhibit PARP activity, but if HRR is intact there, still cell will be repairing. But when there is a homologous recombination deficiency in the cell, or there is a mutation, and then we use the cancer drugs which are inhibiting PARP, and that will be resulting into the cell death. That is a simplified way of describing the mechanism. This is another way of depicting this, that single strand breaks they normally repaired by the PARP system, but if we put PARP inhibitors there, it will be stopping the repair mechanism by these two mechanisms. One is the base excision repair will be inhibited, or auto PRylation will, what it will do, it physically stop the replication. So it's called also mechanism also called PARP tapping. And by both of these mechanisms, the single strand break will convert into double strand break. Now this double strand break will or could be repaired if there are homologous recombination proficient cells. But if there is a deficiency in the homologous repair mechanism, then this cell will turn into cell death, means because DNA will not be repaired in these cells. So how PARP inhibitors, they are playing role in the treatment development. So as of now, there are two, olaparib and rucaparib. They have been approved in the USA. They approved in the May of 2020, a couple of weeks apart. And olaparib, the first was the rucaparib. It is 600 milligram BID, and it is indicated for the germline or somatic BRCA1 or BRCA2 mutation, who had previously received therapy with a novel hormonal agent like next generation AR inhibitors. And the olaparib dose is 300 milligram BID, and this is also approved for the HRR gene mutations in at least one of the 14 genes. So both of them are about 14 to 15 genes. Any mutation in those are the currently approved drugs. Olaparib is not recommended in patients with the PPP2R2A mutations, because in clinical trials it did not show any effect, and when there is no effect, there is no point of putting patients through the toxicity of the drug. So in order to summarize my thought here, we have still a lot of opportunities to further develop this precision medicine and using the PARP inhibitor. So deep understanding of the molecular makeup of tumors has brought opportunities to develop more precise treatments targeting tumor vulnerabilities. PARP inhibitors are example of this step forward precision medicine. So once you have, like, you screen your patients specifically what particular mechanism will work on a particular tumor type based on mutations or wild type, then you can precisely treat those patients. So designing combination therapies with PARP inhibitors is ongoing, and one of them is androgen receptor signaling pathway. If you combine the PARP inhibitors with that, they have a much better effect. So these are the one studies I just mentioned. Olaparib, this is most recent data they presented in February ASCO GU meeting. This is olaparib with abiraterone acetate, and this is again still being studied in the homologous recombination deficient patients. This is another compound, niraparib. This is another PARP inhibitor. And this is also this was also reported in February. And the difference between these two studies is the olaparib is effective only in the HRR deficient patients. However, in the niraparib study, they have shown that it is effective in irrespective of the HRR status. So, I mean, there is a possibility that there could be the indication could be expanded to a larger population. So there are, with that, we have, since it is sort of in beginning in this direction, means the precision medicine using the PARP inhibitors, particularly I'm talking about. So there are challenges. So I have just pointed a couple of those or three of them. Developing validated predictive biomarkers. It's important that we have those which particular genes are mutated. So out of like those 14, 15 are available, those could be done, but we need to have precise method for that, and also to quantify what is the proportion of that. Then identifying DNA repair deficient tumors in prostate cancer, so you can select your patient population. And then as of now, the technology is not so user-friendly for physicians who are making decisions with their patients in their office, so that if that needs a little bit more room to simplify that technology, so physicians can easily look into that and select their patients. So in the end, I would like to summarize my thoughts is that successful development of PARP inhibitors has resulted in an effective therapeutic option as precision medicine in prostate cancer. And we have evidence with these two products already approved, and these PARP inhibitors are also approved in, for example, breast cancer. Multiple of those, at least 6 of them, are approved in the US. So there is a very good possibility to develop that further. And these treatments exploit a tumor vulnerability that in normal conditions makes these tumors more aggressive and constitutes one of the prime examples of success in precision medicine today. So with that, I would like to say thank you very much for your attention. And Chair will plan, I can take questions now or later on, whatever, if there are any questions. Thank you very much.
Thank you so much, Dr. Om Sharma, for that amazing presentation. And as we have discussed earlier, probably we can have the question and answer session at the end of the entire, the session, so that, everybody can participate and cross question as well. So we have our next speaker who has joined us. We have Dr. Human Soli Mani Machar, consultant gynecological Churchill Cancer Center, Oxford University Hospital, UK, who has joined us. Very warm welcome, Dr. Human. Very warm welcome to you. Can you hear me?
Yes, thank you very much. Yes, I could hear you really well, and I hope that you could hear me well as well.
Yes, so we would request you to please begin your presentation.
Yeah, so just kindly let me know if you could see my presentation.
Yes, now we can see the presentation. Yes, please go ahead.
Fantastic. So just bear with me. We okay. Can you see me now?
Yes, please go ahead. We can see the presentation. And
excellent. Fantastic. Yeah, so many thanks for kind invitation. I think it's an honor to be here, and I'm going to take you through the role of ultra-radical surgery and the latest surgical development in the management of advanced ovarian cancer. This is the practice we have been undertaking in Oxford University and Churchill Cancer Center for years. Just to start with, I have no conflict of interest to declare. And I start by saying that the definition of optimal debulking in the management of ovarian cancer has changed over the years. And we know now very clearly that in order to achieve a better survival, the intention is to leave no residual disease when it comes to ultra-radical surgery. Now, we knew that for many years that one of the reasons we couldn't manage or achieve no residual disease or optimum debulking was the disseminated carcinomatosis, especially from the survey which was published by Eisenkopf in Gynecology Oncology in 2001. We realized that one of the biggest problem or the main stumbling blocks for the gynecological oncological surgeons to tackle upper abdominal disease, especially the diaphragmatic metastases, the portal disease, and disease involving the small bowel mesentery. Professor Bristow undertook this meta-analysis looking at 7,000 patients and found for every increase in a 10% increase in the maximal cytoreduction, we would have seen 5.5% increase in median survival. Again, what we found was an independent risk factor for survival was no residual disease. We published our first paper work in Gynecology Oncology in 2015. And in this paper, we compared the role of neoadjuvant chemotherapy versus primary debulking surgery. In this study, we had inclusion and exclusion criteria. And one of the key exclusion criteria was to perform laparoscopic assessment to rule out any disseminated carcinomatosis, because we knew that the CT scan had limitations. We published this then in Gynecology Oncology about the laparoscopic assessment on the top of the CT scan to make sure that the disease is operable. And in this video, I will show you that how important it is to do this assessment prior to embarking on ultra-radical surgery in the management of ovarian cancer, because the CT scan could easily miss these dots, or what we call disseminated carcinomatosis, especially on the large and the small bowel. You could see these dots are miliary disease on the ascending colon. And also we assessed the small bowel and the large bowel. We have 1.5 meter of large bowel and nearly 9 meters of a small bowel, which we would not be able to assess by just this CT scan. We tend to do this assessment before exposing the patient or putting the patient through an ultra-radical operation, which is normally on average takes 8 to 10 hours. This assessment is done a week or 2 weeks before, and you could see we know now what kind of disease you're dealing with.
Dr. Masjid,
yes.
Your slides are not progressing. Are you moving to other slides? Because you're only
No,
one.
oh, this is a video I'm trying to share with you. I apologize if the video is not shared. I mean, might be the internet, but I'm playing the video and I'm screening with you. Is this just frozen? Are you saying it's frozen? If it's frozen, I apologize. It's a video which I'm sharing, but I will make a progress by moving to the next slide. If that is, could you see this one now?
Not yet.
No, okay, that's very strange, because can you see me now? Can you see the slides?
Not slides. We can see you, but not your slides.
Not the slides. Okay,
Can we share on your behalf?
I think it says it's shared with you on my side.
Maybe unshare and then share it again. Sometimes it works.
I'm doing it again.
Yeah.
I'm doing it again. That's
Puneet, can you help him?
So I have.
Yes, we have your presentation. So can we share?
Yep. So
just
I'm sharing again.
Mm-hmm. You can see the slide, the first one.
You can see the first one. Can you see now?
No, it's still first.
It's still the first one.
Mm-hmm.
That's very strange. Let me
and you
just
see moving on your screen, right?
Please share the full screen rather than a window, sir.
Okay, just bear with me.
From our side, the slides can be shown.
You can stop sharing and sharing once again. You share the full screen, sir.
Is this a full screen shared now? Because it says screen.
It's just coming up.
Yeah, it says it's shared.
No, not yet.
Maybe
share screen, full screen. I mean, like desktop types.
Yes, I have shared my desktop with you.
Yeah, it's coming up. Next slide.
Okay. Okay. Is this okay? Is this great? As long as it's shared with you.
Yes, it's coming.
Yeah, now it's coming. Now it's moving.
Is it moving now?
Yes. Yes.
Excellent. So I apologize. I deeply apologize. That's a computer glitch. So yes. Now, can you see it now?
Yeah, we can see.
Yeah. Okay. So then we moved on to publish our next paper, which was on the on-block resection of the pelvis. Again, we standardize a technique, and my colleagues who deal with the gynecology oncological operation are familiar with the fact that when you go and remove the pelvic tumor, often everything is completely matted, and you could see here that we were left with the largest specimen, which constitutes the rectus sigmoid, uterine body, and cervix, tubes and ovaries, and pelvic and the bladder peritoneum. So just to share with the colleagues who don't do ovarian cancer surgery, we often subject the patient to this pubic midline incision, which is a large incision, and we use this equipment, which is called Buchwalter, and we try to navigate around the abdomen and pelvis from all quadrants to be able to tackle the disease. We have to be very cautious on the long operation, which I often call this is like a long haul flight. You have to be very careful, and one of the things we are very mindful of is called leg compartment syndrome. So we watch the patient's legs like a hawk. We then have to compartmentalize the operation to different steps, and we know by now the ultra-radical operation is the way to do this operation. And we start the procedure by doing the radical omentectomy. We have to be very cautious not to compromise the blood supply to the stomach. And after radical omentectomy is done, we have to make sure that the stomach has a good blood supply and is not hyperperfused, has gone through the ischemic changes, because the ovarian cancer tend to involve the greater omentum and lesser omentum to extent, and this is a larger specimen of radical omentectomy which we have performed. Stomach has 5 blood supplies, and try not to sacrifice more than 3 out of 5 when we perform this operation. Then we have to open the lesser sac and expose the pancreas in its entirety, head, neck, body, and tail, and also make sure that we are doing this properly, and also assess the bursa omentalis, make sure there's no disease involved. I'm trying to show this video with you and share it with you. I hope that you could see the video. This is a disease which is involving the lesser sac, and this is the gastrohepatic ligament. And we have done the radical omentectomy here, and now we have been left with this nodule. Again, you've got to be very cautious to remove this disease. One of the key things is, doesn't matter how much work we have done so far, we do not want to leave any disease behind. And these are the cases that in the past used to be called not operable or inoperable. Now, with very careful surgery and very good intraoperative planning and perioperative planning, we're able to undertake this operation without any problem. And this is what we call a nodule in the gastrohepatic ligament, which is excised and removed. Now, we then had to move on to liver mobilization, which is my special interest, and also diaphragmatic surgery. And in order to do that, we have to do a Pringle maneuver, which has been around for years, which is basically a slinging the portal triad to make sure that the liver is fully exposed. And if you have any bleeding from the liver surface or during the mobilization, you have full access to the porta. And again, that emphasized the importance of the anatomy. The other organ we have to tackle is the spleen, which is very important. Often is involved with the metastases, and we know up to 15 to 30% of the patients who undergo primary debulking surgery, they need to have the spleen removed. Now, with the role of neoadjuvant chemotherapy in the management of ovarian cancer, we try to reduce that. And after a splenectomy, of course, it's very important to make sure the patient gets the vaccination and also be mindful of the sepsis. Then we publish our paper on Untitled classification, which is a type of liver mobilization we do, and our 11 steps. And I've just put the paper as a reference. It's very important to be able to mobilize the liver, because when the liver is mobilized, then we could and we should be able to see the disease. In this animation, I'm just trying to show you by removing or mobilizing the liver, you have to divide the coronal and triangular ligaments of the liver. And often the disease in the bear is in the bear area, which is the retrohepatic area, also known as Morrison pouch. So this is a very common place for metastases. So it's very important that we mobilize the liver and try to access the suprarenal area and also adrenal gland on the right side, and also try to expose the inferior vena cava, which is in the retrohepatic phase. And in order to do that, you have to really and safely mobilize the liver, because often you find extensive disease here. That moved on to this example of how the liver is fully mobilized and diaphragmatic peritonectomy is performed. And then you can see in this picture the adrenal gland and also all the Abraham vessels and the retrohepatic inferior vena cava is exposed. And that took us to the paper we published on the role of portal hepatic peritonectomy. Again, it's very important to be mindful of the vasculature here, and I showed in that video that the disease is spread in the porta. Then again, knowing the upper abdominal anatomy is extremely prudent and important for gynecological oncological surgeons these days when they do ultraradical surgery. And then we went on to see the role of diaphragmatic peritonectomy, either full thickness or peritonectomy only, which was my research in Oxford. And we often end up removing a very large piece of diaphragm which has disease. And again, in this video, I will show you that how important is to fully mobilize the liver. And if I show you, you will see that the liver is mobilized, and often you find a nodule, a very big nodule, sitting right on the diaphragm, and you cannot see that necessarily with the laparoscopy. You need to mobilize the liver fully, and there's a CT scan of this lady, and then at the surgery, I show you that we have mobilized the liver fully in its entirety, and we are removing the diaphragm. And this is a full thickness resection of the diaphragm, because in the study we did, we realized actually 60% of the patients will have the disease spread to the muscle of the diaphragm and 20% to the pleura. So it's very important to remove this disease in its entirety. Even if you have removed disease everywhere, you should not leave any disease behind. And if you have selected the patient for ultra-radical surgery, which is extremely important. And again, we went on to publish how to reconstruct the diaphragm in this video. I think I should be able to show you. I hope that the internet is not a problem on your end. But these are the patients coming, and now in the past we were not able to work around the diaphragm or remove the cardiophrenic lymph glands, which are very common places for metastases. You can see in this video, we have mobilized the liver. We're just trying to do diaphragmatic peritonectomy by mobilizing a very large piece of diaphragmatic peritoneum over the diaphragmatic muscle. And there on occasion, you need to really access the chest completely. And diaphragm is one of those areas, it's not very clear who owns the diaphragm. The ownership of the diaphragm between the cardiothoracic surgeon or hepatobiliary surgeon or the gyne-oncological surgeon depends on the type of disease you treat. And in gyne-oncology, we know that the ovarian cancer like to metastasize. And this is an example of how the cardiophrenic lymph node can be easily accessed through the chest. This is a transdiaphragmatic approach to the cardiophrenic lymph nodes, which we have excised. And you can see in this picture, we will then, in this video, we have shown and published how we would reconstruct the diaphragm back. And normally, and very rarely, we will use a mesh, because the primary closure is doable, is feasible, in safe hands, and actually in selected group of patients, we can just put it back with a stitch, and actually it doesn't cause any harm. It used to be a taboo to work around this area, but now it's very much common practice, and is part of the surgical skills we do own and have in our armamentarium. So that would take me to my next slide, which is the role of cardiophrenic lymph node assessment. We're the first group in Oxford that we published on the role of assessment of the cardiophrenic and actually excising it after neoadjuvant chemotherapy. Again, is quite doable, and we have published how we do that in this video, which is quite important to be able to excise this tumor. And again, if you have achieved no residual disease elsewhere in the left upper quadrant or in the pelvis, and you have been left with this big cardiophrenic lymph node, why don't you try to remove that as well? And again, a lot of criticism would be on the survival and the quality of life and the morbidity around this operation. But I could reassure you, with good clinical governance in place and constantly and continuously auditing your practice, you should be able to have a good outcome and also good data on the morbidity. Now, what is going to take me to my last slide, which I want to say and share with everyone, is that holistic approach to patient's care is very important. It's paramount. Basically, we assess the patient for fitness for operation. We need to fully understand the risks and benefits and alternatives to surgery. We need to be very honest and transparent with our patient. Do not make them false hope. We do not offer them things that we do not know. And needs to be really carefully consent them for the operation. We do a laparoscopy to be able to tell them exactly what the operation would entail. And also remember, we should not cause any harm to our patients. We need to be very caring and compassionate when it comes to treating these patients. I just heard from my other colleague speakers that this approach to the patient has to be very compassionate and also very scientific and academic and the patient-centered, and also always appreciate the potential of impact on the quality of life and against the survival benefit. Thank you very much.
Yeah, thank you so much, sir, for that wonderful presentation. And I would now request the the next speaker for the session to please go ahead with the presentation, I'd request Padma Shri Dr. Harsh Mahajan, founder and chief radiologist, Mahajan Imaging, and also Chairman Kevin. Dr. Mahajan, over to you.
Thank you very much. I'll just get my slides going. Are you able to see my slides?
Yes, sir. Can you make it?
Yeah, I'll just do that. One sec. Sorry about this, but just don't seem to be able to find.
So
at the bottom.
On the top, there will be a presentation mode.
Yeah, I'm seeing that.
You go towards the bottom.
Yes, I'm at the bottom and I don't see that icon, you know.
Oh, I see. So at the bottom bar, if you go towards the right, where you have the percentage or size of the.
Yeah, more. I've done this so many times. I don't know why.
Slideshow. It will be.
Yeah,
maybe.
Yeah, on the top, there will be a slideshow option.
I'll do that.
Maybe you want to add enable editing. Maybe it's not allowing you.
Slideshow is there.
So, but if you allow in editing, perhaps then you can probably
from
see
beginning, sir.
Okay.
Yeah.
Yeah. No.
Can you see now?
There is slideshow, but
no, at the bottom. Can you see now?
No, I still can't actually.
Oh, I see.
It
so,
says.
But right. I mean, you can see the slides. So even if you're not able to see it on the entire.
No, I'm sorry about this because I've done this hundreds of times earlier.
Please press from beginning, sir.
Yeah.
First one from
beginning.
beginning.
You can just click F5, first line of your keyboard.
No, here it says from beginning, the first one, first icon.
This one? No, that's
on top, sir. On top left side, below
from
5.
beginning. Okay, my God, that worked like magic. Thank you very much. So, sorry for this little problem. I will be taking you through what we believe is the current and the unfolding role of artificial intelligence in oncology. As we said, the way forward, not only in oncology, but in medicine as a whole, and more importantly, in diagnostics and radiology. So artificial intelligence, we all know, is not a new term, coined in 1956. And there are two broad categories. One is artificial narrow intelligence, where, you know, Deep Blue, the IBM chess computer, beat Garry Kasparov, the world chess champion. This is that the computer learns one task and is able to do it brilliantly. And then is artificial narrow general intelligence, which is the emerging field. This is the next frontier. This is where everyone is trying to build algorithms where you teach the computer one thing and it's able to self-learn other things. And this is where human beings are. And of course, we talk about artificial superintelligence, which we hope never comes, when robos will actually rule the earth. There are two broad categories of AI applications. Things which humans can do, but AI can do better and faster. And this is multiple CCTVs. AI can look at hundreds of them. And also Google Translate. You may know the language, but it knows many more and can do it quicker. And something which humans cannot do, which we use on a daily basis, and this is our Google Maps. Humans will never be able to forecast how long it's going to take and what route to take. Now, AI algorithm, we won't go into details, but first we need to find data. Then that data is fed into a computer which trains the model. Then the model is validated on the data on which it was built. And then when it goes to another hospital or a diagnostic center, we test the model on a different data set which belongs to that hospital. And this is where all the problems come, where something that's claimed to be 99% accurate becomes 50 or 60. And this is what we as a group are trying to solve this conundrum. Now, if we talk about the radiology value chain, AI has potential to impact at each and every level. The various steps are patient scheduling and preparation, the actual scanning and image acquisition, the processing and analysis, the measurements and all that, and of course the holy grail, which is diagnosis. And we'll see how AI is helping in every part. Now, this is a paper from 2018. Machine learning predicts patient wait times and appointment delays. This is a big thing in a radiology department, and there's AI tool available today in use which can predict these very, very well. Then predicting scheduled hospital attendance. I mean, you book patients and patients don't show up, some of them. So you are booking today for the 5th day, and today you are sitting free because the patient did not show up. This tool can very nicely predict which out of the 30 patients you book today, which out of them will not show up. Then we talk about scanning and image acquisition itself. This is a paper we presented a few years ago at the ISMRM and the European Congress of Radiology, where from just T2 weighted images, we were able to predict diffusion weighted images, which are used for stroke, they are used for cancer. This is work we did in stroke, but just as to be able to show that this can be done. So the computer had learned, had seen previous diffusion image, T2 weighted images and diffusion images, and then this time was shown just T2 weighted images. This is a true diffusion in a chronic infarct in the left frontal lobe, and there was no diffusion restriction seen even on the virtual diffusion image. This is another case, true diffusion showing an acute infarct, and the same, to our great astonishment, 3.5 years ago, the same shown on virtual diffusion. These are two other cases where you have multiple chronic infarcts, acute infarct. Only the acute infarct is to be shown on diffusion, and that is what we were able to see on the virtual diffusion also. Similarly, a tiny little infarct seen very well. So here we showed for the first time that you could, using AI, actually show images which hadn't been actually obtained, and maybe this is one way in which MR times can be cut short. Then we did this for PET CT as well, and this again was presented by us in the ECR RSNA 2018 and ECR 2021, pushing the boundaries of deep learning based image translation, creating PET images from CT images of the lung, only CT images. And this is a CT scan which was shown to a computer. This is the true PET CT, true PET image, and that's synthetic PET without actually doing the PET. These are fused images, CT. This is true PET. This is synthetic PET. And that's another case showing the same with a central hilar carcinoma. This, of course, is a peripheral carcinoma of the lung. Yet another case, central carcinoma, hilar carcinoma. And again, so the day may come, these are initial days, but a day may come when you show the computer a PET image, a CT image, and it gives you PET CT without actually doing the PET. Then improving image quality by reducing scan times. This is what is the true image, and with artificial intelligence, we've got this pristine image quality. And again, the same low contrast image by using very low dose on CT scan, and this was FDA approved 3 years ago. And so you can actually use these algorithms, and some of them are already in use, low dose, and you're using AI, you're able to reconstruct pristine quality of images which do not lose any data. Then processing and analysis. And here, automated liver, vessel, and tumor segmentation done using AI. It can give you the liver volumes, it can give you tumor volumes, show you the blood vessels, all done automatically. And you know, cancer surgeons and a physician's eyes really light up that maybe a day will come when they don't need the radiologist who's generally not available. This is fully automated brain tumor segmentation, again, using AI. And this is deep learning for variational multimodality tumor segmentation using PET-CT, where the blue is the automated and the pink is what was done manually. So AI is going to play a major role in the years to come in segmenting tumors, whether for surgery, whether for radiotherapy, what have you. And now the holy grail, the diagnosis. And this is our paper from the Lancet. And this was the first paper in the Lancet on AI in healthcare. And this actually looked at brain hemorrhage. But, you know, going forward, this will also have a role in tumors and what have you. This was done with our partners, Cure AI. And, you know, this showed that with 0.94, 0.96, area under the curve, you could pick up hemorrhage, but still slowly these are going to come into day-to-day clinical practice. Then automatic generation of test reports using AI. This is also something that is not far. And also this is our paper at the RSNA. AI doesn't hedge when reporting on chest x-rays. Radiologists used to say could be, maybe, should be. It was seen that AI doesn't hedge as much as we radiologists tend to do. Then this is again a paper we presented along with our partners from Bangalore, you know, on nodule characterization on AI, and lung nodules could be automatically detected. And this again is nearly 3 years ago, ECR 2019, and it picked up the nodules, also gave you the sizes, the volumes, and outperformed 3 senior radiologists for characterization, whether it's malignant or likely to be benign. Possibly mammography will be the one oncology application where AI will become mainframe in use very early. And we saw that brilliant work from Niramai, which was presented earlier today. And this is something where, you know, there are millions of mammograms done around the world and millions which don't get reported, especially in the developing parts of the world. AI, I'm sure, will play a great role there. And not just digital mammo, but also in MR mammo, and this is from UPenn, where they've developed an AI algorithm for this. We personally feel that AI will lead to integrated diagnostics becoming a reality. And what is integrated diagnostics? Oncodiagnostics, radiology, pathology, genomics, and all of these currently work in silos. Whereas what the oncologist needs is a synopsis of the entire tests that have been done, put together, digested, and given to him as a whole. Now, this is huge amounts of data, and there are points where there is intersection, and we need to move beyond the traditional radiological pathological correlation barrier that exists. And we believe that it is AI at the back end which will help do it. We already have integrated tumor boards using AI, and this is something from one of our collaborators, Sectra, where everything, the X-ray, the pathology, the histopathology, all of these are presented side by side, and this instantly resolves any discordances, provides a reconciled report, and it improves quality, reduces risk, and has instant potential, especially in breast cancer. So here again, this is something which will soon be in use, where tumor staging, radiology, pathology, surgery, the follow-up, the clinical, all are presented in a single patient-centric window to the clinician. Digital integration has already started, and this is one such example. The future of radiogenomics, where genomics data, detailed imaging data, be it PET, CT, MRI, clinical follow-up data, the treatment data, are all fed together to give one whole with machine learning systems at the back end. Now, also we believe that the future of screening and preventive health checks, the so-called, predictive medicine, the personalized health checks, where there is integrated diagnostics, is an example. Genetic risk by exome sequences, acquired risk by detailed history taking, current status presented by whole body MRI or any other imaging that may come, which will answer these questions which a patient asks, which a person who comes for screening, actually not a patient, asks, do I have cancer right now? And what is the best screening protocol for me? And what is my chance of developing cancer in the future? We believe the hospital of the future will have an integrated diagnostics department, which the clinical departments will interact with, where this is one whole, where there are diagnosticians, the radiology, biochemistry, genetics, pathology, clinical information specialists, all put together. And I personally believe, having been used to digital data for decades, the radiologist is best suited to become this, integrated diagnostician of the future. So the Integrated Diagnostics Institute will have computational sciences and AI, innovation, diagnostic optimization, population health, and integrated screening, disease-based, whether it's oncology, neurodegenerative disease, cardiometabolic disease, pediatric, what have you, and clinical diagnostics, imaging, pathology, genomics, all integrated into one institute. This is our attempt at it. We envisioned this about 7-8 years ago, and today I'm happy to say it's become a reality. In the basement here, we have 3 MRI scanners and a dual energy PET CT. In the first floor, molecular imaging, PET CT, gamma camera, entire complement of nuclear imaging along with lutetium therapy. We have on the second floor ultrasounds, X-rays, CBCT, DEXA, all the imaging tools. On the third floor, artificial intelligence, scientists, engineers, radiologists, genomics and routine pathology, biochemistry, microbiology, and on the fourth, teaching and training spaces. So this was our vision, and this is what it looks like now, and inaugurated only on last Sunday by the Honorable Vice President of India in New Delhi. And with this is our foray into precision personalized medicine with this integrated diagnostic center. And we do believe that in a radiology setup, this probably is the first genomics and integrated medicine, integrated diagnostic setup on the planet. We are also building the world's first end-to-end validation and deployment platform for medical imaging, trying to bring AI from the bench to the clinic, a tool which is able to help AI developers do validation, testing, fine-tuning of AI before deployment into hospital systems or diagnostic imaging systems. This tool is currently deployed at Harvard Medical School, Stanford, Thomas Jefferson, Emory, among so many others around the globe. Now, what is the future for young doctors and physicians, with these major changes occurring in diagnostics, as will also happen in the field of therapeutics? We feel that AI will work as a radiologist assistant, improving productivity and quality. It will replace radiologists for certain areas of reporting. It will help clinicians like you read scans and may lead to turf erosion, and battles with the radiology and nuclear medicine departments will help in reading scans in underdeveloped parts of the world with limited number of radiologists. There are, of course, still questions regarding liability of AI-generated reports, who actually is liable. But one thing is definite, it'll improve turnaround times and reduce healthcare costs. So I leave you with these words of Jack Welch, the legendary chairman of GE Medical Systems, who said, change before you have to and control your own destiny, or someone else will. These are some of the groups we work with, both in the academic as well as in these big companies, startups like Cure AI, Kibim, Lunit, Predible. And frankly, I believe that it is only through collaboration that innovation is going to come from the bench to the clinic. Thank you so very much for giving me this opportunity to speak to you. Thank you.
Thank you so much, Doctor, for that amazing presentation. And with that, we come to the end of this session. And I think we have enough time to actually also have a question and answer session. So I'd request if anybody has a question to ask, please go ahead. Okay, there seems to be no questions from panelists. So I'd request all the speakers to please conclude the session with your concluding remark. So I'll request Sir Dr. Mahajan to please go ahead first and give your concluding
Thank you very much. Thank you very much for organizing this. And we saw some fantastic work that is being done around the world. Our colleagues who shared their work. And I sincerely believe that technology will be a game changer. Genomics is already making a major difference. And when we are able to marry data together with the strength of AI at the back end, not only in diagnostics, but even in therapeutics, it would have a huge role to play. Genomics already uses AI in so many aspects. And I think the basic requirement is collaboration amongst different fields of medicine, amongst different geographies, so that we can bring these technologies into clinical practice as quickly as possible. And also remember, especially in our parts of the world, the costs have to be as low as possible so that maximum people can make use of these new innovations and breakthroughs, both in diagnosis as well as treatment. Thank you.
Thank you so much, Dr. Mahajan, for that those remarks. And Dr. Geeta, if you could summarize the entire session and give your concluding remarks, Dr. Geeta. I think Dr. Geeta probably.
I think she left.
Yeah, probably she's there. So I'd request Dr. Om Sharma to please present your concluding remarks after listening to all the presentations today.
Sure. Thank you very much. First of all, I want to really appreciate and thank organizers, Dr. Garg and Dr. Aishwarya Kapoor, for this opportunity to come here and discuss the current status in the drug development, basically. So I think I'm very much encouraged that era in the drug development in industry used to be like you take population and then you conclude your outcome based on, of course, we still do risk benefit based, like all the health authorities approve drugs based on that. But it is more of precision medicine time. It is more of genomic detection time to find the particular patient, find the particular mutations in those patients, and target your therapy. So to avoid the unnecessary toxicity, at the same time, you can enhance the efficacy of your whatever drug you are developing. And with the combination of what I heard from Dr. Mahajan, and which we know that from the AI is a major thing going forward. So combining genomics, combining AI is the future of developing individualized and precision medicine. And we are entering in that era. And to me, it's very exciting. And this was a good forum to really share some of my thoughts here and what we have been doing. I have been in industry for a long time, and I was in academia also. So I can see from both sides. I spent 15 years in academia and 30 years in industry. So I can compare and contrast that for the main, our goal is our patients, and how we could really bring. One thing is everybody should have access to medicine. The other point is financial thing. It's not, even in I can talk about US, it's not really equally accessible to all kind of economic status people. So our goal is to bring medicine to everyone, irrespective of their financial situation. And then the other part which we are entering these days is to reduce the toxicity, generalized toxicity, and target the effectiveness by targeting and precision medicine. And thank you very much.
Thank you so much, Dr. Sharma, for those remarks. And I request Dr. Human now to please present your concluding remarks for this session, sir.
Yes, I mean, thank you very much. I mean, it was an absolute honor to be here today, and I thank Professor Anil Kark, it's also Professor Mahajan. I really enjoyed the panelists' talks and presentation. It was quite interesting, and also there were state-of-the-art presentations. I think I echo my other colleagues and other speakers, the role and the value of collaboration. I think I would say that with the digital era we are living at the moment, we are able to share our knowledge quite rapidly and quickly. And I hope that I know that we are all singing the same song. We're all trying to look after our patients at our best ability. And I really hope that in future we see less and less pain in our patients, and actually continue to collaborate and boost on these collaborations globally to be able to take care of our patients at all levels all around the world. It was an absolute pleasure, and I'm looking forward to be here again if it's needed, and I'm looking forward to see you back in Oxford hopefully very soon. Thank you very much.
Thank you very much for all distinguished speakers for excellent presentation. Padma Shri Dr. Harsh Mahajan for giving account of what is relevant at this moment and what is latest technology is doing in the healthcare industry. We will meet in person next year on 11th and 12th April, and we will send you invite for that. And so we will do something great for the humanity, poorest of the poor throughout the world. Thank you very much. Thank you very much.
Thank you so much, gentlemen, for having joined us. It was indeed our pleasure for a very invigorating session that you have witnessed to it. Dr. Geeta Manjunath, Dr. Om Sharma, Dr. Homan, and Padma Shri Dr. Harsh Mahajan. Thank you so much, gentlemen, for having joined us. With that, we come to the end of the day one of the World Healthcare Conference. We have had excellent sessions since the morning. We dwelled upon various aspects related to healthcare. And tomorrow we'll have the second day of the conference, and there are other important topics that are going to be discussed tomorrow as well. So we're looking forward to your participation in the conference tomorrow and in future as well. But it was indeed a great session. So I thank all of you for having joined us in this conference. Thank you, gentlemen. Have a great night and take care. Thank you so much.